afternoon, and I hope you enjoyed your lunch. We've got a wonderful afternoon of speakers ahead of us now, and I've got the distinct pleasure to introduce Professor Imogen as our first speaker for this afternoon. Many of you know Professor Imogen Mitchell, I'm sure already, but she's the director of the ANU Medical School as Senior Medical Advisor at the Australian Commission on Safety and Quality in Healthcare and Senior Intensive Care Specialist at the Canberra Hospital, working for Canberra Health Services. And Imogen will be talking about the provocatively titled talk, Dying Surrounded by Emotions. Thank you so much, Professor Mitchell.
Thank you, Michael. Oh, can't do this right. Sorry. So yes, many thanks, Michael, and to Hannah for allowing me to provide a presentation in this amazing day of talks. So very humbled to be speaking. So I guess I suspect you've seen this already, but it probably is quite poignant to myself as an intensive care specialist, in as much as intensive care is quite a difficult environment in of itself. So even if you're a patient who doesn't die, that's going to be always left as a memory for you and your family. And I guess the next step, of course, if you have a relative who dies in the intensive care unit, we need to really make sure that that experience is as positive experience as possible, because there is no doubt if it's a difficult death, then that will live on forever in their hearts going forward. And I think it is something that I have at the back of my mind all the time when I'm working with families, particularly if someone is dying. So I thought perhaps it just sort of set the context what intensive care might feel and look like. And then, of course, what does that mean for the patient who's dying, and what do we seemingly do or don't do in the intensive care environment, and how might it differ to the rest of the hospital, and then obviously to the community as well, and what are the sort of next steps that we should really be looking toward. So for those of you that are not that familiar with intensive care, it is quite a daunting experience just walking into the intensive care unit, because you're surrounded, as the title alludes to, is that lots of machines, of lots of noise, and it is not a relaxing experience. And if it's frightening for our junior doctors and our junior nurses, it is definitely frightening as a family member, and even more frightening if you're the patient, whereby your life is on a knife edge and things could go very badly, that is, you might die, or hopefully it goes well. Now, it should be said that I say only 10% of the patients who come to intensive care unit die. So not everyone who comes is actually dying, but there is a significant proportion of patients who do die within our intensive care unit. And so if we have 2,000 admissions a year, that's 200 deaths that we will be experiencing. And as a hospital, we probably see more than any other geographical area. So it is something that we're quite used to, although treat everyone as a special entity. As I said to you, the environment is very noisy, and it's not pleasant, and it's certainly not pleasant 24/7, and people and patients find it very difficult to sleep. And of course, there's always lots of uncertainty coming in as an intensive care patient or family, because you're not quite sure what's actually going to be the next thing and what might go wrong or what might go better. And there's this definite sense of losing control, and losing control over decisions, over life and death. And I guess we try and work with families to make sure that that loss of control doesn't feel quite so bad, and that we work with them to make sure that there is a much better understanding of what the next steps might be. But again, this is more of a generic comment, but if we look at, what does a high-end quality or high-quality end-of-life care look like, it's seemingly that the patient has a deep sense of spiritual peace, relieving burden and strengthening relationships as you move into your dying days, and having your loved ones close by. But this is always in the presence of losing one's sense of dignity. We really dehumanize people, particularly, or patients within the intensive care unit, by removing, your pajamas, that you've really, really not, I guess, having any sense of dignity at all. And loss of meaning, I mean, you have been removed from your life, you're seemingly now not able to act as a parent or as a child or as a work colleague. You really haven't got that sense of purpose, you're really trying to fight for your life. And this real sense of burden to others, that you are totally reliant, completely and utterly upon other people, whether that's to bathe you, to do your teeth, to brush your hair. You cannot actually have that often within the intensive care unit. So I guess if we're trying to look at high quality end-of-life care, we need to be very cognizant of those things, to try and maintain some of those things as well. So one of the things that we clearly need to focus on, and the Robert Wood Johnson Foundation found that these are the key elements, the 7 elements of delivering quality end-of-life care that I'm sure you've heard about already. So that there needs to be a strong focus on patient and family-centered decision-making. We really put high emphasis on communication, and probably we're one of the few areas within the hospital at least that we take time away from busy work lives to spend with patients and families to make sure that there is a good understanding of what's happening and what is likely to happen. Providing also a continuity of care with the nurses and the doctors so that we all know what the next steps are, so there's good handover, good communication, and that we are there to provide emotional and practical support and hopefully symptom management as patients might move into their dying days. And should the patient wish some spiritual support, we would do that as well. And that within our own intensive care unit, there is a clear understanding of the procedures and guidelines as to how we might manage dying within the intensive care. So that's kind of, if you like, the gold standard framework, which we would hope that we address. But obviously what we think we're doing is not necessarily what we are actually doing. So one of the things that, as an organisation, I think 3 or 4 years ago, was that we wanted to understand what is the dying process at the Canberra Hospital, recognising that many people would prefer to die at home, but we know that probably still the majority of people are dying in the acute care hospital. But what does that actually look like in terms of duration, in terms of timeframes, and who's involved in decision making or who's not involved, so we can get a better understanding of what does it look like now, so what could that look like in the future. And certainly we started to have a good understanding in our own hospital, but then we started to ask the question, well, what's happening nationally? Are the things that we can learn nationally? As I just said, apparently 60% of us, although now start to question those data, say that we would prefer to die at home. And so clearly at the moment, the opposite is happening, is that 60% of us will be dying in an acute care hospital, which I don't think is adequately supported to provide the best experience as people go through their dying days. And so when we then start to focus, well, where are people dying in the hospital, the acute care hospital? And you will see from a 9-hospital or so study that we decided that we would look at, is this just general where quite a lot of people are dying in the intensive care unit at Canberra Hospital, but is that being reflected nationally? You see on the right-hand side, the numbers will vary depending on which organisation you're looking at. So in one institution, only 19% of their deaths are occurring in the intensive care unit, where another organisation, 36% of their patients are dying in the intensive care unit. Why are the differences happening across nationally? Is it a resource issue? Is it a philosophical issue? What are the differences? But there's no doubt in my mind there's a big spread across the nation, and these will represent at least 6 jurisdictions across Australia. So we haven't got any uniformity in terms of way we're managing patients in the dying process. And of course, why do patients get admitted to intensive care unit in the first place? And there's this huge tension between what we can do and what we should do. And it's always easier, particularly at night time, as a junior, inexperienced person, to say, well, it's much easier to do stuff than actually not do stuff. And so this is what happens, is that you tend to find that decisions will be made by default by junior, more inexperienced people of admitting patients to the intensive care unit than saying, well, actually, I'm not sure this is the best outcome for a patient that they get admitted to the high-end, very interventional areas such as the intensive care unit. And so there's this tension, if you like, between us curing patients in the intensive care unit, or should we actually think more globally and bigger into the sort of more palliative end of someone's life. And so if we want to cure people, we'll be saying that we need to do everything. We need to intubate people, put them on a mechanical ventilation, dialysis, the whole works. Or should we start to think, well, is that actually of benefit to the patient and their family? Should we be supporting them in terms of symptom relief? And there's this real tension that the decision at some point needs to be made of which direction we're headed in. And sometimes you can land up in a halfway house, which is fine if that is in the patient's best interest. But again, I talk about the tension of deciding, we must do everything because we love this person so much, we must do everything. But is that actually what we should be doing? Because in some respects, intensive care is this beautiful form of torture, which is fine if it is actually going to be of benefit to the patient. It is not fine if it's actually of no benefit to the patient at all. And all that we've done is prolong death, and all that we have done is make it the most interventional and probably not looking at symptom relief and not making a very positive experience for the patient and the family then walk away having had this real difficulty in terms of having a very interventional death right at the end. And bearing in mind that certainly in our organisation, 40% of patients who die at this hospital. So that kind of sets the scene in terms of the tensions and what we should be looking at. But let's see what we actually do within the intensive care unit across the nation. So this is looking at 9 hospitals across the nation in terms of what we actually do in terms of the dying process within the intensive care unit. So this was a study supported by the Australian Commission on Safety and Quality in Healthcare, and it was asking people in, 9 hospitals to allow us to, follow patients in a retrospective way of what actually happened to them during their stay in hospital, and we focused also in those patients that were in the intensive care unit. So as I say, it's a retrospective study. In the end, we had a sort of we caught something like just under 1,700 patients, and we were looking at patients who are adults, so 18 years and older, over a 12-month period, and really looking at patients who died within the ward environment but also died within the intensive care environment and focusing on those patients. So we tried to get representation in that 12 months of patients who fall into the category of dying on the ward, dying in the intensive care. And we're just going to focus on the patients who died in the intensive care unit. So if you look, there were, as I say, nearly 1,700 patients. As you can appreciate, the age range, obviously those that die in the hospital are going to be older. But if you look at the patients who are coming to the intensive care unit, you don't get quite as much representation of those that fall in the older bracket. So someone somewhere is, I guess, gatekeeping that we're not admitting as many older patients to the intensive care unit to die, presumably because they have comorbidities and may not actually survive that particular experience. Less will be coming from a nursing home, so again, a triaging is happening. And also, you can see that many less patients have an advanced care plan when they come into hospital, coming into the intensive care unit. So someone somewhere hasn't thought that these patients are likely to die. So if you look at decision making, who's actually, in terms of consulting families when they come into the intensive care unit, was again, as I said to you, the advanced care plan is much less common when you come to the intensive care. It's not very common in the hospital, so 12% of patients who die have an advanced care plan, but only 3% if they're admitted to the intensive care unit. But in terms of, are the families consulted in terms of resuscitation plans, it goes up that the most patients, although probably not as high as one would wish, only about 50% of patients do we actually talk about end-of-life care, resuscitation and goals of care as they go forward. And again, you'll see that 20% of the last row, 20% of families are actually requesting that we should actually stop treatment before we actually do. So that's presumably something that we need to work on much more closely. If we look at does palliative care get involved in intensive care patients, the answer is no. And that may well be a resource issue, may also be a philosophical issue that we believe we can treat the symptoms as well as palliative care. But I strongly suspect it's probably more a resource issue. The other challenge that we have is that we seem to do interventions post-comfort care initiation, so that you'll see that whilst the vast majority will receive comfort care, subsequent to comfort care being initiated, we will continue to do interventions. And so I guess you can't start to question, is that appropriate or not? So things like vasoactive drugs, imaging still start to occur even though we've initiated comfort care. So again, is that the right thing that we should be doing? And then overall, obviously in the last 48 hours, is that we do a huge number of interventions just before the patient dies. And that, I guess, is symptomatic of being admitted to intensive care unit, and then we have to, have a short duration time between us saying, we're going to take away things that are not working to then the patient dying. So we're doing intervention right up until the last minute, effectively. Do we involve social work? Well, we probably involve social work more in the intensive care unit than, say, on the ward environment. But it seems maybe this is just a trend that we're tending not to focus on the religious aspects, but maybe because we're becoming increasingly a non-religious population. So, in summary, I think we see that there are a large number of patients who do die in hospital but are dying in the intensive care unit. We have seemingly a large number of interventions just prior to death, and is it something that we really need to focus on and step back and say, well, firstly, should they be admitted to the intensive care unit in the first place? And that's, I guess, where I would like to see more conversations happening, is in the ward environment. And I think we also need to focus very heavily on the patient and family experience as we move into our dying days. And on that note, I shall finish.
Thank you so much, Imogen. I open the floor to questions, reminding us that we do have roving mics and we are streaming, so please, if anyone can raise your hand if you've got a question for Professor Imogen. Thank you.
Thank you very much, Professor Mitchell. Fantastic talk, as always. I just wanted to ask you about this intervening, this sort of flurry of intervention before people die. What do you think the motivation for that is? Is that coming from an attempt to please the family, or is it from a professional sort of imperative to do what you can before, just in case?
I suspect it's multifactorial. It's always hard to say no, whether you're the patient or the family or the healthcare professional, because there is this sense that you must do everything before a patient dies. And I suppose what I would like to see is that the conversations of what is in the best interest for patients needs to happen further upstream, so that people are given a very clear picture of their journey and what the things they may expect along that journey. And intensive care may be in that journey, but intensive care may not be in that journey. And I guess I'm not completely convinced that picture is always clearly drawn for patients and families of the expectations along that roadmap, if you like. And the trouble is, these situations often occur out of hours. So if you see the percentage of conversations happening by the home team is about 30% of the time. And so you say, well, 70% of the time those conversations are happening not by the people who know the patient best. But the reason for that is the home team's only around 30% of the week, because it's a 9 to 5, Monday to Friday. So I think we need to also readjust our headset and say, well, either the out of hours team has those conversations and make them good, clear conversations, or we say, well, hang on a minute, the home team really, if they fall certain criteria, they must have those conversations. So the SPIC, which is a tool which helps us understand whether the patient is likely to survive the next 12 months, and if they're not, they must have a conversation, but by someone who's experienced and prepared to make a decision. It's actually someone who's got to be prepared to make a decision. This is not in the best interest of the patient, and that then articulated back to the patient and the family.
And my apologies, but we are on a tight time budget. much. So thank you for all the hands. I'm not sure if Professor Mitchell will be staying around for the coffee break later and perhaps able to answer some questions. I think that was a nod. Great. So maybe questions in the break. Thank you so much, Professor Mitchell. If we can just thank you. I'd just like to welcome our second speaker for this afternoon's session, Professor Michael Woods. Professor Woods is a Professor of Health Economics at the Centre for Health Research and Evaluation at UTS and a visiting scholar at ANU. He's on the board of the Australian Digital Health Agency and a member of the Aged Care Financing Authority. He's been involved in a wide range of different activities, as you can see from his bio if you get a chance to read it. Just to introduce Professor Wood's topic this afternoon is up on the screen, but it's around improving the availability of palliative care, identifying unmet need at the local level. It's a really fascinating topic. Thank you very much, Professor.
Thank you. Thank you, Michael. Thank you, Hannah. And thank you, everyone, for coming to this terrific day. When I see the number of speakers and the number of topics, it really is a very intensive course in understanding what is happening in the PAL care space. So I'll give a quick introduction. The person who actually knows everything about this, because she did the work, is Siobhan Dickinson, who's a PhD student at our centre, so she'll do the middle bit and I'll do the wrap-up bit. It's always daunting speaking after Imogen, because she actually is at that interface and knows everything that happens, but happily Siobhan also knows what she's doing in that space, so I'll just fill in the middle. We were asked by PalCare Australia to look at the local level of unmet need. You know, the mantra of palliative care and the quality of your dying is a bit of a lottery. It depends on so many things, whether it's location, what particular diseases, other morbidities you have, cultural, financial, all sorts of issues. And so they said, can you look at how we assess unmet need? Well, that's pretty simple, except for three basic things. One, we don't quite know how to measure that demand. So, you know, what is the need? What are the statistics on it? What are the thresholds? What are the structures you use to assess that demand? The second is looking at the word unmet. Well, what is the supply? Who delivers it? Where do they deliver it? What quality are they delivering it at? It's one thing to deliver care, it's another to have high quality care. And we need to remember that. So that's 2 out of 3 is that we don't know anything about. And then the third is what's an organising framework in which you bring together that information to assess what the local level of unmet need may be. Well, unfortunately, there wasn't one of those either. So, you know, we struck out on 3 out of 3, but that's not bad. We thought we'd better start somewhere. And we thought we'd start at the third, i.e. what's the organising framework within which you would bring this data? I mean, it's fascinating having bits of data about bits of things, but if you can't put them into some framework, then you can't develop the policy analysis and you can't start to develop programs and benchmarking and analysis in that space. So we started at the back end and said, well, let's develop a PalCare performance framework to underpin this ongoing assessment of performance. So we looked around and said, well, who's got performance frameworks? Well, happily, both the OECD and the Productivity Commission, and I should confess that I used to be its deputy chair, but putting that aside, it does an annual report on government services. And it looks at healthcare, but it also looks at education, and it looks at community services. Dare I say, it actually looks at the justice system and the police. Mind you, they get very indignant if you think you're going to do a performance assessment on them. But nonetheless, it's the one organising framework that you can apply across all services. So we said, well, why can't we do that for palliative care? What's the underlying principles? What's the structures that we can use and apply it to palliative care? And then we said, well, what do we talk about with palliative care? So we went safe and conservative and adopted the WHO definition. The benefits of starting at the back end and having a performance framework is that allows this standardised assessment of the service delivery across services, but across regions and across time. So it allows that level of analysis. It allows for comparative performance evaluations or benchmarking, so who is doing better than who and why. But it also allows agencies to assess their own performance over time. So you can say, what are these indicators and are we actually improving over time? I'd like to show you what we've done on palliative care, but as Siobhan will show you, we're still at the front end of that. But let me show you something. I'd like to see palliative care in this space sometime very soon. But so this is just an example of what has happened looking at, this is looking at girls in a particular year fully immunised against HPV, but it can be a whole range of different things. But what you can see, and this is done at PHN level, but you can do it at different spatial areas wherever you've got the data, but all of a sudden you can see over 1 year the level of performance of different regions on this one indicator, and then over years you can then say how is that performance changing for each of those regions and overall, and then you can go in behind that indicator and say what's happening in terms of a whole range of factors that Siobhan will now describe to us.
Hi, I'm Siobhan Dickinson. I've been working with Professor Woods to work on this palliative care framework. So I'm going to take you through how we thought about palliative care to come up with this framework, and finally what we found when we applied it. And unfortunately, everyone's told you the punchline. There's limited data out there, so that's where we are. So we thought about palliative care, and you saw that Patsy showed you the palliative care service framework, the triangle. We thought of it in terms of 4 key stages, and you can see the first key stages align with that palliative care, living with a life-limiting condition. But the first stage there is sort of pre-palliative care, and that's when you know that people will eventually need palliative care at some stage. The second stage went into living with a life-limiting condition, and you could see increasing symptoms, and people may enter the palliative care system there. Then as you go down the trajectory or the continuum, there was end-of-life care and terminal phase. And importantly, each of those requires a set of services or ongoing needs, depending on where the patient is along that continuum. So that's what our framework really recognised, that patient needs are dynamic, that patients and their families have, consistent with the definition, holistic care, and we recognise that our framework needs to take into account different changes as they, for example, assisted dying legislation. So when we looked at those frameworks that Mike outlined early, the Productivity Commission and the OECD frameworks, we found there were key concepts or key themes that kept coming up. There was equity, effectiveness, safety and quality, and efficiency. What we did was then we disaggregated those key concepts into a hierarchy of performance goals, indicators, and then sitting underneath indicative measurable indicators, and they are indicative for a reason. When we applied the framework, we found that those indicators could be complete, partial, or aspirational, and they're pretty much what they sound like. We had one complete indicator, most were partial, and aspirational basically meant there was very limited data. Don't try and understand all of this, but this is pretty much what it looks like. And you can see there that the orange boxes are the 4 key concepts that we came up with. The blue boxes are the performance goals, and the red boxes are the performance indicators. And there's a box down the bottom that's grey, and I'll take you through that, why that's grey. So the first key concept was equity, and equity relates to the ability to access services according to need, irrespective of financial barriers. And a couple of barriers that we thought about were financial, cultural, linguistic or socioeconomic barriers and regional access barriers. Moving on to effectiveness, we looked at that relates to when services are achieving the desired objectives. There's two key concepts. There's access, which relates to accessibility and availability and timeliness of services, and appropriateness. The third was safety and quality, and that's a key measure for a lot of the healthcare system, obviously divided into three goals: safety, responsiveness, and continuity. Finally, efficiency, and we've highlighted that was important earlier today. Looked at inputs per unit of output and government expenditure. That's not actually an efficiency measurement per se, but rather something that the government might be more interested in. So we trialled this at Sydney North and Murray, and just to compare the two, obviously Sydney North is an affluent area, has a higher than average life expectancy, whereas Murray is an area of socioeconomic disadvantage, has a lower life expectancy, and for those who don't know, it's a regional area and it sits up in the northwest corner. There's quite a few services provided in Sydney North. And they have done a bit of work there. I won't take you through everything, but the good thing is, of course, that there is work being done at the PHN level, which captures some of that community focus. And Murray, on the other hand, has also done some work, although service providers are more sparse in the Murray PHN. So when we applied the framework, basically what we found was there were many data sources, but of course it's limited. The key data deficiencies related to non-cancer palliative care patients, primary and community services, carers, and of course at the regional level. But I'll hand you back to Mike for concluding comments.
Thank you, Siobhan. So that's a thumbnail sketch of what it looks like. In terms of what we can draw from that, one is that it is possible to construct an organising logic to look at this question of unmet need, and we've developed this framework that, and by trialling it in a couple of PHNs who are very, very supportive, and we thank them for that, it allowed us to test the model, and they were very constructive in helping us move it to its next stage. Is there something that we think has benefit if that would be able to be produced nationally, come out, say, every second year? When you think of the Productivity Commissioner's report on government services, that comes out every year. The media love it, the oppositions love it, the providers love it, the treasuries love it because they can see what their state departments are doing. So there's a whole lot of interest in this space, and if we were to be able to do the same in palliative care, then at least every second year there'd be a major focal point for discussion about where palliative care has got to and where it needs to go next and where the weak points are in the system and the like. So it's a very valuable tool, not only for those who are in the system, but it's a valuable tool for accountability to the wider community and to the funders and to the regulators as to what is happening in this space. So we think that there is considerable benefit. It needs to go through a second round of pilots. So if you've got a friendly contact in the department and want to ring them up and lobby them for stage 2, hey, I didn't mention that. But I would have thought, looking at Canberra and also looking at the surrounding region, given the different demographics and access and related issues, would actually be quite a nice part of a stage 2 trial. So we're very keen to see if that can be brought into being and to learn from that, because this has got to be an iterative process. Now, the other point which Siobhan raised is that a lot of the data points there are either only partial or aspirational, and people say, well, why do you bother putting them in if there isn't any data? Well, that's the whole point, is to say, this is what you would need if you want to understand what is happening. We don't have the data, or we've only got some data and it's not very good data. We'll put in the not very good data with lots of caveats, but we want to indicate that. And we also want to put in the spaces where there isn't data, but you need it if you actually want to come to sensible conclusions and good policy analysis. So that's why you have lots of gaps, but you'd have them deliberately there to give you that agenda on the way forward. So thanks to the various collaborators, and particularly Palliative Care Australia for providing the money, bless them, but for all those colleagues. They're the data sources we use, they're the references, and thank you.
Thank you so much, Mike and Siobhan, for really fascinating work, and likewise I share your interest in knowing a bit more about how that would look in the ACT and surrounding regions. Questions are welcome. Nikki, if you can just wait for a microphone, that would be wonderful. And I see, thank you.
Hello, thank you very much for your talk. I saw residential care there. Is that residential aged care, and if not, I'm just wondering about different funding arrangements, Commonwealth and state, that provide different services, and has that come into it?
So there are two issues there. There's one is, what is the quality of care and the quality of dying that is occurring? And the second is, under whose jurisdiction and who's paying the dollars. This one focuses primarily on what's the quality of care, the access, the efficiency, the effectiveness of the care. We've separately done some work for LDAC and got a paper on community level palliative care and in also care in residential aged care facilities. So yes, there are all sorts of interfaces there. There's separately some work being done on trying to clarify in the aged care space, and I do a fair bit of work in that one, on differentiating between what's a health intervention and what's a care and support intervention in the aged care space. Now, Kathy will also have various views on that, but it's important to understand the differences between those two systems. Aged care is not a universal, everybody gets it because you've got old system. Aged care is about care and support for people as they age, and there are subsidies for those who can't afford that care and support, but it's an essential thing for them to have. That's different from universal health care. And we just need to keep that difference very clearly in mind, because people think, I've got old, I have an entitlement, it's a universal system, how do I get in and how do I get my lawns mowed or my gutters cleaned or the housekeeping done or help me showering as a matter of course because I'm entitled to it.
Can I just say, just add one thing to that? If you are under an aged care package, a Commonwealth package, the state won't walk through the door.
Yeah.
So it actually means you may get less care.
Yes, yeah, there are all sorts of things, and residential aged care as well. I mean, the same with access to health care in residential aged care. Getting the GP to walk in the door is an intriguing exercise itself. I've just done a review on multi-purpose services, which are the 180 aged and healthcare centres around rural and remote Australia. And it so much depends on whether the GP will take on admitting rights and actually cooperate with that little local community hospital and aged care centre. Just so important. Yes. Happily, the nurses are there and doing a great job, and my mother-in-law died on the weekend, and the nurses were fantastic because they are there the whole time and they understand the process and they can communicate it to you, and they know where your loved one is at, and yeah, it's a beautiful experience with a very high quality nurse there holding your hand.
Yeah, thank you. Another question here.
Yes, thank you. I'm a neonatologist, so I'm going to ask the obvious question for me. This seems like a very systematic way to address needs, but have you included, or would it be possible to include the needs of paediatric palliative care, or kids that have grown to be adults that have lived with their chronic condition and are now requiring adult palliative care services but started their, I guess, condition as a child?
Yeah, this can then differentiate into the different broad groups. I mean, everyone's unique, but nonetheless you can still differentiate into broader groups. And yes, if you're talking about the quality of care, was it accessible, was it timely, was it professional, did it meet their needs, and then the quality of that delivery. You can do that for all palliative care interventions because that's what it's about. It's not, I mean, sure, if you're talking for the older age group and oncology and things, there's separate well-known trajectories, but there's a whole lot of others that don't get the same attention. This brings it all together into one single organising framework.
Can I get you to join me in thanking Mike and Siobhan again for the presentation? Mike and Siobhan, are you staying around for the coffee break? May or may not be available, but Siobhan will be here. So if you have any complicated questions for Siobhan, then she'll be available in the break. So thank you so much again. And it's my pleasure to welcome Professor Di Slade now to give a presentation. Di, for anyone who doesn't know her, is Professor of Applied Linguistics and Director of the Institute of Communication and Healthcare, the ANU.
And also Suzanne Eggins is talking as well.
Susanna, fantastic, and I think Lisa's involved in this project as well.
And Imogen, yes.
And Imogen, so lots of people involved in the project. Now I think, if I understood right, that just due to challenges in communication, Di's presentation will probably take up most of the time, so we may not have time for questions, but there may be an opportunity in the break again. So thank you so much.
Thank you so much. Thank you very much, Hannah, for asking me and my team here. It's a great privilege to be here with you all. We're going to, in our short amount of time, talk about a small pilot project, which is an ANU-funded cross-disciplinary project, which brings together a group of linguists working in the field of communication and healthcare. So Susie Eggins, my colleague, Liza Gontroff, who's here, and myself, with medical academics and clinicians, Imogen Mitchell, Michael Chapman, as well as a critical health psychologist, Brett Schultz, who's talking in a while, and a bioethicist. So it's a wonderful collaboration between linguists and medical clinicians, and also other disciplines involved in this kind of work. Imogen, I want to thank very much, who was the inspiration behind the project, and Michael was a great supporter of it from the word go and has been really critical to it. So it's focusing on effective communication during end-of-life interactions in the intensive care unit in the ICU. So what we're saying about end-of-life interactions is, because it's a tiny project, $15,000, it's tiny, we can't generalise beyond the context in which we're talking about, which is the ICU. Okay, so just very quickly, why would you want to look at communication in end of life? Patsy Yates gave a wonderful plenary where you talked very convincingly about how critical communication was. So I really only will say this very quickly, but we did an extensive literature review, and the research around the world consistently shows that if done effectively, end-of-life conversations result in improved clinical outcomes to patients. They actually decrease anxiety, depression, and loss of hope. They reduce distress to carers in helping to make end-of-life choices. Also interestingly, a converse to that is poorly conducted end-of-life conversations often result in unnecessary or harsh treatments. But also research has shown that if doctors fail to communicate empathetically, for example, just one example, using very technical language, not trying to make it accessible, not really listening to the patient, often that can have the opposite effect, where they feel threatened by it, so therefore they actually employ forms of denial or minimising the significance of the information. Okay, so what are the project aims? So what's interesting is that what was evidenced by the literature review, there's very little systematic investigation of doctors' actual communicative practice in end-of-life conversations. So the overall aim of this project was to try to do that. It was to describe and analyse actual communication practices in end-of-life conversations in the ICU, to identify ways doctors can enhance their communicative practices during end-of-life conversations, and to inform the development of communication protocols and interventions. It also is going to provide a basis for a future larger project on end of life. So what's our methodology? Our methodology is a translational methodology where what we do, which is a little bit unusual, ethnographers around the world interview, observe. What we do is actually go in and record video, audio, in this case, for obvious reasons, it was only audio recorded, actual consultations. We then transcribe them, de-identify, and carry out a very detailed discourse analysis of those interactions. then we go through those interactions with our medical and other allied health clinicians. So we did 30, it's because it's small, we did 13 interviews, we audio recorded at 8 actual clinician-family conversations. We then did post-conversation interviews with the clinicians. And then after we've done the analysis, the critical phase is the translation of that into making an impact in practice. So the so what question. So we, even with this small pilot, we are hoping to show you today a little bit of how we're going to translate the findings to inform the development of communication protocols. So the important thing about the recording of the conversations, why do we do it? What people say they do in interviews is very different than what you actually do. So it really provides a very powerful insight into what is actually going on. Okay, so just very broadly before I hand over to my colleague, these are very provisional findings, but our preliminary observations from the actual recordings show that there's 3 dimensions that impact on the effectiveness of end-of-life conversations. The first is the context, that is participants and the environment. So is the conversation taking place and an environment conducive to sensitive communication? Have all the relevant people been invited? Secondly, structure, which is where our communication linguistic focus comes in. What is the overall sequence of the stages? That is, what's the macro structure? How are these stages related to a shared understanding of the goals of the interaction? The third dimension is that impacts on the effectiveness of the communication is the communication strategies. What we mean by communication strategies are they're the micro local level. So they're the strategies used to achieve the conversational goals. So for example, validating a patient or carer's concerns. These strategies are dynamically adapted according to how the interaction proceeds. In really highly sensitive, stressful situations, the dynamic unfolding of the interaction is particularly critical. So for example, not going in with a fixed protocol, but listening carefully, reacting to what the family is saying. So what do we mean by effective? We look at the actual consultations to see if the reactions and responses of the participants imply understanding, satisfaction and appreciation of the implications of the conversation, and also how clinicians elicit and react to the participants' contributions. So I now hand over to Susie, who we won't be looking at the first one for lack of time, but we'll be looking at the structure and the strategies.
Thanks. Okay, so in this framework, the first thing that struck us when we looked at the conversations from the ICU was that, of course, there isn't just one type of end-of-life conversation going on. There is, of course, a very big difference between whether that conversation is with the patient or with the family and carers. But the main thing that struck us was there's a very big difference between, in terms of the goals of the conversation, between whether a decision needs to be made. The conversation is happening because a decision needs to be reached, or whether this conversation is happening to give information, an update. If it's a decision conversation, and the majority in our corpus are decision conversations, what matters there is the timing of that decision. Some conversations are about we need an immediate decision. This conversation has to happen because we need a decision now. Or it could be about there is going to have to be a decision in the future, but this conversation doesn't have to reach it. The content of those conversations where a decision needs to happen could be, most of the time, is focusing on withdrawing or withholding treatment in the ICU. It's obviously a very sensitive issue that needs to be talked through with the families, or on goals of care post-transfer. So whether this patient should come back to the ICU if they deteriorate when they're sent to the ward, for example. Okay, so why do conversational goals matter? The goals of a conversation shape the structure and the unfolding of the interaction. As Di said, it's kind of the macro or the template for the conversation. And in the ICU, in particular in these very, very stressful situations, the goals need to be shared with participants because what's being looked for is a consensus, shared decision-making. Right? So everyone needs to know the goals so that they understand what the purpose of the conversation is, to reach a decision or to get an information update, for example. Knowing the goal also is part of that is knowing how then this interaction is going to proceed, who's going to start, what's going to happen as we go along, how will we know when we've got to the end. And it's very important that the goal is shared so that participants know that their participation is integral and encouraged. So for this reason, goals are typically, in the data that we've got, stated very clearly at the start of the conversation, and it needs to be in language, of course, that even very distressed participants can grasp. So here's a couple of examples from our data. So the doctor says, now this is with the patient. Now what I wanted to talk about was just to give you a little bit of information about where we've been in the last couple of days, and then to talk to you about what you would like us to do in the future when you have similar illnesses to this, okay? Before I start, do you have any questions? So very clear goal statement in very everyday language. A second example, this one with a family. So I guess it would be helpful for me to understand your understanding of your husband's journey, and then the concerns that you have and how we work together with yourself, and then obviously with the rest of the children, because I think the end point is that at some point we all need to get onto the same page. This is more a deferred decision. A decision doesn't have to be made in this conversation, but it's going to happen. So while we say that the goals are very important because they provide the overall structure for the conversation, we all know that interaction unfolds dynamically. You cannot know in advance how it's going to go. It unfolds turn by turn. That's the nature of talk. And this is why doctors also need to be ready to adapt their conversational style and content in light of participants' responses, their contributions, their needs, their preferences. This is a big ask in such a stressful context, of course. So a clear goal provides that overall structural template that can get things going in the right direction so that everyone is on the same page, more or less. From the data that we've collected, we see this structure emerging quite clearly, particularly for the decision-making conversations, that there needs to be an opening in which those goals are stated very clearly, followed by an overview which outlines how decisions are going to be reached, that it isn't a one-way process, it's about consensus. How's that going to happen in the conversation so that people know that they're welcome to come in at any time. There's going to be a stage typically of knowledge sharing. Then there will be a decision point which needs to be raised in the conversation. There will then be negotiation around that, and there needs to be a closing where there's a summarising of what the decision is and how that will then be operationalised, what's actually going to happen next. Now, when we looked at the conversations, a few issues did emerge with the goal statements. Sometimes, for example, the goal statement didn't seem to be an accurate reflection of what the intensivists seemed to need to do. Okay, so it wasn't entirely, what they said at the beginning wasn't necessarily quite where the conversation seemed to be going. And sometimes the goal statement used expressions where the meaning wasn't necessarily clear to participants. Clear to the intensivists, of course, but the participants, the family members, don't necessarily know what it means to say the patient should not come back to the ICU. That's a shorthand if you work in an ICU, but it's not at all clear necessarily to outsiders. So that's on the overall side, the goal, the structural side of the conversation, some suggestions and evidence from the data. At the same time, as I mentioned, there's this dynamic turn-by-turn unfolding, this need to be able to adapt. The main challenges in building consensus in an ICU end-of-life conversation are that there are very, very marked differences in a number of areas. First of all, medical knowledge. There is not an equality in medical knowledge. You have people with an enormous amount of medical knowledge in a conversation with people who often have relatively little. There's a huge power imbalance. And don't for one moment think that patients and families are not aware of this. We have in the data people saying, well, are you sure it's okay if he stays in the bed there? He's taking up a bed. Okay, so they're people are very sensitive to this power difference. And expectations, of course. Clinicians may have very realistic expectations, families not so. And the emotional involvement, of course, is very different. So the use of strategies, conversational strategies, is happening against this background. What we saw in the data is a very impressive range of strategies that are being used in conversation to build consensus with family members, so very much working towards shared decision making. And I've listed quite a few of them here. I'm only going to give you examples of a couple of them, but you can see a lot of it is about inviting the participants to recount what they understand is going on, and then giving back to them the information that they need, inviting questions, shifting from the use of we just to refer to the medical team to use we to refer to all of us in this room making the decision. So an inclusive use of pronouns. And very interesting strategies of repeating and gradually amplifying negative prognosis or risks to recovery. And this is sort of damping down expectations. And sometimes very, very sensitively using the words coming from the family members themselves, but sort of recasting those in a more realistic way. So just a couple of examples. Here's one of the intensivists saying, in terms of what we see at the moment, I can see that the patient is struggling with his breathing and looks quite uncomfortable. Is that what you've witnessed this morning? So immediately asking for feedback on that judgment. Family respond, in terms of where we go from here, I think we're reaching a point where there's not very much we can do that's going to help him. Waiting for reaction and its agreement, okay? Concern is at the minute he's suffering, and that's why we wanted to have a conversation about where we go from here, right? So awareness of what's going on here. The doctor says, do you have any strong opinions about what you think's happening? I just want him to be kept free from pain. So in this case, the doctor is really holding back and saying, here's the situation, is that what you understand? Do you have an opinion, okay? It's not always going to work like that because this is a very high level of consensus very early in the conversation. Sometimes it's going to be quite different. So often what we saw in the data was the intensivists needing to do quite a lot of dynamic work to reinforce and amplify the meanings that they're trying to get across. So here, this is just only the doctor's contributions to a segment of the conversation. And if you look through, you can see the doctor gradually getting more and more explicit, repeating, amplifying what they're saying. So starting off saying, there's nothing I can fix. It makes me think, well, what are we trying to achieve here? The next time, in the end, this might not lead to something that's permanently better. His quality of life is not great. There's nothing I can really do to fix it. So there's a lot of repetition here and explanation of that. So what this means is, to what end are we just trying to prolong his death? So the actual use of the important word there. And then saying, reporting what the patient has said and saying that is, he may well die and not go home. So this gradual building up of the amplifying of the meaning with a family that may be a little bit less realistic in their expectations. So there are still some issues with what we saw in the consensus building. I mean, it's an incredibly difficult thing to do and was managed so well in the data we looked at. But a couple of issues that came up. Is the family's decision making based on a clear understanding of what it means to come back to the ICU? So do they really understand? People can only share in a decision if they really understand what that decision is about. And is it perhaps problematic that there can sometimes be an ambiguity around shared understanding and shared decision making? Okay, sometimes families don't know who exactly is making the decision, and that is not necessarily the same thing as sharing the understanding. Do some ways of talking risk preempting consensus? Okay, I think we have no answer for this. We're giving this back to you as an issue to think about. But are there perhaps, what is the line between giving information, waiting to be asked for advice, and volunteering, a position? How do you manage that? Very, very difficult in the actual situation. And what is the ICU's role in formalising those documents that have come up a few times today already in presentations, these legal documents about end of life? Does the ICU have a role in that or not? So I'll hand back to Di now just to do some conclusions.
Okay, so in conclusion, we're translating our findings into communication frameworks. Firstly, for how to structure the overall consultation according to the goals of the interaction, which Susie's already discussed. And secondly, we're developing an evidence-based framework for describing the communication strategies. So, we're categorising those communication strategies according to two language dimensions. It's the informational dimension, so how medical information is explained and shared. So it's the what, the content. And the interactional dimension, how participants are included and how their contributions are validated. What we find in the very good protocols that are around, like serious illness or the other ones that are around, like Validate, they're really wonderful, but they often have a mix of the structural elements, how the overall conversation should proceed, and also mixed in with communication strategies. And so what we're trying to do is say, okay, let's bring out some of the very best elements of those and put them into a more language-based framework. So the protocols, for example, will say, be empathetic. But what does being empathetic mean in communicative practices? So what we've done is we've come up with informational communicative strategies that are inclusive with examples from the actual data. So, for example, seek and recognise the patient's carer's knowledge and opinions about their condition. So these are evidence-based from the data. So and we haven't got time to go into them, so there's more of the informational ones. And also we have the interactional ones. For example, recognising the patient and carer's perspective. So we are going to keep refining this over the next few weeks when we're doing the analysis. But what I want to finish on is a wonderful quote that came out of the transcripts. It was a consultation, and it's the husband talking to the doctor about the treatment that his wife had had. And to me, it absolutely says how brilliant we thought the care was in the ICU. It was extraordinarily impressive, their level of consensus making and their empathy. The thing that has struck me about our time in the ICU, so this is a husband, is the personal interaction between nurses and doctors and us. It made me feel that my wife is the only patient in this area and that all of your energy has been directed to her. And the feedback what you were giving us in layman's term just makes us feel valued. I think I know as much as a layman can know about what's going on with my wife. And you don't pull any punches, and I'm glad for that. And you painted a pretty realistic picture. Thank you very much.
Thank you so much, Di, and to your whole team. It's a really, really fascinating, important work being done. Having said we don't have time for questions, we may have some time for some questions. So we're being dynamic in our communication strategy over the course of the afternoon. Are there any questions that anyone has for Di and her team? Yes, Rachel, so waiting for the microphone. Lovely to hear from you.
So I'm just wondering, obviously this is good stuff. I'm wondering about patients and carers who where English is not their first language. And I've read some work around the fact that using interpreters can be quite problematic. And I wondered if you could shed any light on how we could perhaps think about educating interpreters so that we can actually move this sort of work into a space that would work for more complex families.
Okay, there's an area that we haven't researched, and I think that's a very important area. Or what I feel is that if you do a detailed analysis of what actually is going on, it's quite different than what's in many communication protocols and a lot of the stuff that's included in training. So I think the power of the authentic is really critical. So the only way I could respond to that, and I think it's a very superficial response because I haven't really thought about it, so you haven't done research, I mean, in that area, although it's critical, is that interpreters equally, I think, can really effectively, if they're interpreting into English, for example, from whatever language, have a detailed understanding of how they would expect consultations to unfold. Does that mean but I think it's an area begging for real data.
I guess the research I've read says that we underuse interpreters a lot in acute hospitals and ICUs, but then there's another level to that actually if you don't have skilled interpreters, even bringing in an interpreter can just add another layer of complexity.
And a colleague of all of ours, a medical colleague of Imogen's, Chris Phillips, and a colleague of ours, a linguist, Susie McQueen, are doing wonderful work looking at Google Translate. So whereas what's happening now, it seems to be, but the medical people here would know more than we do, but a lot of doctors are turning to Google Translate rather than using interpreters. And what they've done is shown through a small pilot how problematic Google Translate can be. Actually systematically made, but quite erroneous and serious errors. We're suggesting they write to Google and get funding for the next phase because it's actually very exciting research.
Thanks for the question. Imogen, you had a response?
I suppose from a practical sense, and I completely support, this needs further investigation, but the first thing is actually to get them physically in the room. Because I can tell you, and I'm sure other people have the same experience, it's very hard to have what you guys are describing as the interactional conversation if you're actually speaking to someone on a telephone and then expecting them to translate to the family. I cannot read the language of that person on the telephone. And it's, we obviously do have family meetings not needing an interpreter on the phone. We have families with on the phone as well, and that's hard as well. So having physical presence is a first start for me, but that's a cost issue, and that's probably one of the reasons why it's always probably the last thing we think, now we've got to get an interpreter, which shouldn't be like that, but it's just so hard to get them at the right time and actually get them in the room. So that's just even a practical problem.
Yes. Thank you. Thanks for the questions. Thank you, Diane and team, for the wonderful work. Now I'm really excited to hear the presentation from our next speaker, Nikki Johnston. For anyone who doesn't know Nikki's a nurse practitioner working at Clare Holland House who does most of her work, as I'm sure she'll explain, in working in providing palliative care in an aged care facility context. Nikki has recently been the winner of two really big awards, and she was the inaugural winner of the inaugural Health Minister's Award for Nursing Trailblazers this year, and also she won an Order of Australia medal this year as well. So congratulations from all of us, Nikki, for those, and we look forward to your presentation.
Thank you very much for having me here to speak today. It's an absolute privilege. I've been listening to everything that everyone's been saying, and I think our work brings in many different aspects of what people have been talking about today. So, better lives and better deaths for aged care through specialist palliative care needs rounds. Results from our step-wedge randomised control trial. Why are we interested in this? We've got an ageing population. Everyone who's in residential aged care isn't there because they don't have complex needs. Every single person in residential aged care these days has complex needs. The staff, the workforce, they're doing the best they can. There's not very many registered nurses. There's many carers. Most of them are from non-English speaking backgrounds, and fabulous, beautiful diversity and all of that, but that changes the way we think about death and dying from different cultural perspectives. So the environment that we're working in, the third thing is we've got limited specialist palliative care services across the country. So how can we give this, I think, one of our most vulnerable groups, particularly people with dementia or neurodegenerative disorder who can't talk for themselves. They're a vulnerable hidden group. How can we give them the access to specialist palliative care that they need, and how can we also increase the capability of all of that workforce, which is thousands of people, to be able to do this work? So this is our idea. We've been working on this for about 5 years now, and I'm very happy to say that Michael Chapman was there from the beginning, and Raymond was there from the very beginning. Julianne joined us a bit later. And this is definitely a team thing, it's not just me. Like I said, that there are some barriers. Dying's not recognised. If we don't recognise dying, we don't plan for it. There's avoidable transfers to hospital, and we've heard about the burdensome treatments that happen at end of life. Lots of death in hospital, pain and other symptoms at end of life, they're not recognised. So again, if they're not recognised, they're not managed well. Staff, residents and families are distressed. If people die badly, it does remain in the minds of those left behind. People say to me all the time, how do you do this work? How can you keep turning up, year after year? And I say, because if we make death and dying a normal part of life, and we manage symptoms and we help people to die well, then it's an absolute privilege. I could not be doing this if I was turning up every day and watching people dying badly. And then, if we think I'm like that, what about all the people in residential aged care, all those staff? They're not going to keep turning up if people are dying badly, are they? Either. We've got to look after them. Access to specialist palliative care is not equal across Australia at the moment, and that's due to where people live and geography. Also, it's about their age, their diagnoses, and it's also about funding arrangements. So we've had to come across a few barriers there. access to end-of-life medications is problematic. So 52% of Australians are dying in acute hospitals now. That's increased from 50 a couple of years ago. I think we're heading in the wrong direction. Capacity of primary care providers, so that's people, all of the staff working in residential aged care and our general practitioners. There's room for improvement in terms of caring for people in the last months of life. Low rates of anticipatory planning for end of life, including goals of care discussion and advanced care planning. So in 2015, we did a pilot. Some of you have probably heard me talk about this before. I'll just explain the intervention because it's the same for the trial, the randomised control trial. So our model of care is called Palliative Care Needs Rounds. It has 3 components. The first is the actual palliative care needs round itself. So what that is a monthly, it's a monthly meeting that a specialist palliative care clinician has within the residential aged care facility. It's with the staff only, no residents. We like everybody to come to that meeting, anybody who's interested. We have registered nurses, we have managers, we have care workers, we have team leaders, we have people who are activities specialists, because what we say is that everybody in that everyone in that facility, including us, when we become a team, we're all equally important. We just do different jobs, and we're all as equally important to care for people at end of life. In that palliative care needs round, the first thing I do is teach the staff how to recognise dying. So who of all of your residents is at the greatest risk of dying without a plan in place? So they bring 10 people with no plan in place to this meeting. We talk about who their family is, we talk about their diagnosis, we talk about their alternate decision maker if they're no longer able to make decisions for themselves. We talk about the law around decision making at end of life. We do teaching around symptoms. We do whatever comes up. Whatever comes up, we do communication. We do everything. It's a real space where we're mentoring and giving them all a big hug. Really, they all love it. It's only an hour, and it's really worthwhile. The second part of that, so we've said we bring 10 residents to that meeting. Out of that, because none of them have the plan in place, every single one of those residents in the rest of the month has a multidisciplinary case conference. At the beginning of that time, our job is to teach the staff to facilitate a multidisciplinary case conference, and by the end of it, they're running them. So I've had care workers running multidisciplinary end-of-life conversations and planning. We do advanced care planning and anticipatory prescribing. The third part of it, we haven't seen a patient yet. Oh, sorry, they've been to the multidisciplinary case conference. And then we have our specialist palliative care consultancy. So that's our model. So with our intervention, with the pilot, we did save money, we did stop people going to hospital, people died in their preferred place. Some themes that came out of it were a palliative care specialist who could prescribe. We normalised death and increased the staff capacity to do this work, and we helped with decision making and planning. We did a couple of publications. Then we sort of looked at each other and said, well, what is a palliative care needs round? We didn't really know, so we did an ethnography on that and came up with what that actually was, and we developed a tool which can be replicated so that other people can run palliative care needs rounds. So out of that, the Commonwealth gave some money to do this across Australia, and that's still kind of happening. And then we went on and decided that we needed to make this a bigger trial, because I was the only clinician in the first pilot. So was this the clinician, or was this the model that actually had the good results? So we've just, we finished the INSPIRED trial, where we integrated specialist palliative care using the palliative care needs rounds. We used a step wedge methodology. a randomised controlled trial, 1,700 residents, 12 sites in the ACT, and some qualitative data as well. Step wedge methodology is probably the most ethical form of methodology for this patient group. Everybody starts in control and everybody goes to intervention. Our primary outcome measure was hospitalisations. Secondary outcome measure, preferred place of death. Then we looked at the PEPA measure, which is a measure that we were looking at death literacy and knowledge and building capacity of staff to do this work. The fourth was a quality of death index. So we didn't look at quality of life, we looked at quality of death and dying, and then some other demographics. 2 minutes. This is us all at the end of the trial, actually. This is our team. I've put this up here because the data analysis really took a team. So we've got a health economist, we've got a statistician, and we've got the clinicians and a couple of professors. And we needed all of those because I definitely did not have those skills. Main findings, our results, and I'm so sorry, our results are in peer review as we speak, so I can't really give them out, but I'm going to tell you anyway. And so we mirrored the pilot, and our results were statistically significant for all outcome measures. And we reduced length of stay for hospitals and substantially reduced hospital admissions, saved 2.5 million over the trial. Staff learnt the risks and burdens of hospitalisation, and they were more able to support the residents in the facility, preventing unnecessary admissions. Palliative care needs rounds had led to better anticipatory care planning, for example, access to appropriate medicines for end-of-life care and understanding disease trajectory. Preferred place of death, yes, we did that one as well, improved the ability of dying in preferred place of death. Staff confidence and death literacy was improved. Palliative care needs rounds improved care staff understanding of death and dying, and improved staff confidence. As the trial progressed, there was an incremental improvement in staff outcomes. Staff felt more confident in providing nursing and psychosocial care to residents and relatives. Staff changed their care practices as a consequence of the palliative care needs rounds, and notably in improving pain management. Palliative care needs rounds also precipitated changes in information sharing between staff. Quality of death was improved. Staff reported a shift in people's quality of life and death being improved by the new model of care. So I know that ACT Health is here, and I just want to thank them because we have actually been fully funded to have 4 nurse practitioners across Canberra, so that this model will go all the way across Canberra. So thank you, that's very exciting. We think that this model could be adopted across Australia, not only for residential aged care. We think it could be in small hospitals, we think it could be ward space, we think it could be using telepresence in remote and rural. So there's a real mentoring and educational part of this work, as well as the clinical work. Thank you.
Congratulations, Nikki, and all the team members are here and all that are absent as well.
Yeah.
We probably have time for maybe 1 or 2 questions, if anyone has questions for Nikki. Thank you.
Nikki, just beautiful work for, really human and people-based beautiful work. I wouldn't expect any less from you. But the needs rounds seem very organic, very something that you would think would happen everywhere. Is there no evidence that this is happening in any other jurisdiction?
Do you want to answer? I'd say no. No. So this comes out of integrating specialist palliative care into residential aged care. It's the first time that we've
done this in Australia. There's other models, but this is the first time this one has, and it's because it's a proactive approach. It's an approach that's trying to look at what's actually going to happen and planning for it. So no, we're the first.
Yeah, and
Fantastic.
And we just made it up, you know. We just had this idea and we thought, oh, let's just give it a go.
But I think just to respond to that as well, that there's a lot of intuitive common sense in what we've described, and I'm sure it's actually done a lot in lots of places. And I guess you know, Nikki and the rest of our work is probably the first formalising of it in a way that's been evidence-based, but it's, you know, a lot of it's quite common sense, you know.
Sorry, can I just say one more thing to that? So we're state-funded. Specialist palliative care is state-funded, and we're going into a Commonwealth-funded business. Okay, so us coming together as a team is new.
And just maybe a very quick question just here from Rose. Yes, thank you.
Thanks, Nikki. That was fantastic to hear about that work again. And having been the personal recipient of your work, you know, have an in-depth knowledge of that, and for which I'm incredibly grateful. I do have one question around in this, you know, sort of age of patient-centred care and shared decision-making and all that kind of stuff. Do you see at some point that the resident themselves and their family will be involved in the rounds?
So I'm sorry, I was too quick. I missed that. So we're doing it already. So there's the palliative care needs rounds, which is with the staff. The multidisciplinary case conferencing is where we have the resident, their families, and the staff, the GP and us, and that's where we do shared decision making, and that's really important. So there's the palliative care needs rounds and then that shared decision making case conference. We may never get a specialist palliative care referral because we've done the planning. So there's upskilling of the staff, then there's the planning, and we may never get a referral. So yes, that's a really, really vital, important part of the work we're doing.
So thank you again for the questions. Thank you, Nikki, for the presentation. For reasons which may become clear a little bit later, we're running slightly late, a little bit on purpose. So I hope that's okay with everybody. We'll explain that a little later. But now I'd like to invite Brett Schultz to the stage to talk to us for the last speaker for this session. Brett is a critical health psychologist and research fellow in the ANU. His work focuses primarily on critical approaches to health organisations and systems. In addition to that, Brett is a board member for the ACT Mental Health Consumer Network, and is presenting, you know, in this fascinating area of work in regards to consumer leadership in palliative care, readdressing power imbalances against experiential expertise. So really interested to hear you talk, Brett. Thank you so much.
Thank you, Michael. And thanks everybody for so many thoughts throughout the day, and I appreciate that it's been a very long day, and if you're anything like me, there's probably so much going on in your head at the moment after listening to all of these presentations, so hopefully I'll be engaging enough to, towards the end of the day, keep you active and keep your attention. But I think that was actually a really nice segue, that question from Rose about, you know, consumer involvement. So it was almost as if we'd planned that. We hadn't. But I'm going to be talking all about consumer leadership in palliative care. So first of all, you might be thinking, what's consumer leadership? And I want to start by saying one of my PhD students is doing her entire PhD on defining what that actually is. So I certainly don't have enough time to talk about what it is in any depth. But to me, consumer leadership within any health setting is about ensuring that consumers have decision-making capacity, not just within their own care at that individual level, but at the organisational and the systemic level. So that goes out to organisations, that goes out to policy making and beyond. Policies actually require that consumers be part of everything that we do within health, so that they're part of service implementation, planning, delivery, evaluation. the entire cycle and over again. And we're familiar with that across a number of national standards and international standards as well. Oh, as I alluded to before, there's different sites of leadership. So there's leadership on that individual level, and that's where consumers make decisions within their own healthcare. And that's very important, and I think we've actually heard quite a few examples of that happening within palliative care and beyond. What we hear less of is consumers being involved in organisational and systemic leadership. And when we do, often it's quite tokenistic, but more about that as I go on. In terms of palliative care, when I first came into palliative care and researching in this area, my initial expectation was that we'd actually be doing a really good job of partnering with consumers throughout the entire, sector, because of the philosophy of palliative care as being about, prioritising people's experience and prioritising people's individual needs and so on. But as I say, in the service delivery context, I see that happening a lot. Where I don't see that happening is in organisational levels and policy levels. I came into it and I sort of thought, well, where are the consumers? Their voices aren't necessarily being, they might be being heard, but they're not actually part of the decisions that we're making. They're not necessarily part of the funding decisions that are made in healthcare. They're not part of making policy. They're not part of those things to any sort of extent. There's a lot of paternalism, and there's so many assumptions in end-of-life care as well. The biggest one that I hear so often is that people say, oh, consumers don't want to be a part of this because they're grieving, they're bereaved, they have those kinds of concerns. But then when I ask, well, have you actually asked them if they want to be a part? The answer is often, well, no, we haven't actually asked. But we don't want to necessarily pressure them just in case they don't want to be a part. So there's paternalism, there's assumptions, and it's quite problematic. And it all comes down to power imbalances, which we've heard about in a couple of presentations throughout the day. And I guess my background is in mental health, where the kinds of power imbalances between consumers and services and health providers were about stigma and assumptions about lack of capacity. And I guess my point was I didn't expect to see that in palliative care, yet I still do. I still see these kinds of power imbalances, assumptions being made about consumers, best interests of consumers. Again, I'm talking about the organisational and policy levels more so than the individual care levels. Okay, so when I think about power imbalances and about how to try and redress power imbalances, I always think that we need to be co-producing whatever we do, be that education, be that research, be that policy, or be that service provision itself. And whenever I think about co-production, I always think about this diagram, which itself is an example of co-production. It was co-produced by consumers and government researchers. Basically, there's probably nothing new in this diagram, but the crux of their argument was that if something's truly co-produced, it's co-produced at every stage of a project. So that goes from the planning stage, before the actual work has begun. There's issues with that, and that's difficult to do, and I'll talk more about that later. Through to design, so designing a project would have to be collaboratively done as well. It would then need to be delivered collaboratively and evaluated collaboratively. If all of these elements aren't happening, then co-production's not happening. And I should also preface by saying co-production's not always possible in certain circumstances. For example, to actually plan a project, you often need to you won't have funding at that stage to be able to necessarily pay people. So therefore, not all the voices will be in the room that need to be in the room. More on that later. But just to kind of say, co-production is a standard that we should work to. It's not always possible because of resource issues, because of all those kinds of things that we face whenever in anything we do in the health sector. But I just want us to keep that in mind, that when I'm talking about co-production, it means we're doing everything together from beginning to end. Okay, so I'm going to talk about the findings of two studies that we've been looking at in terms of consumer leadership in palliative and end-of-life care. The first one has been published. You can have a read and download and enjoy. I think it's a good read. I'm biased though. But basically, it's a systematic review to find out, well, what is happening in terms of consumer leadership across the end-of-life care sector. I'm about to get to this in the next slide, but it strikes me here that you can actually even see in the title that it just says consumer and carer leadership in palliative care, academia and practice. We also were curious about if it was happening in policy, but we didn't find any published articles about consumer leadership in policy. That doesn't mean it's not happening just because people haven't published about it, but it didn't occur within the findings. Okay, so we did find studies that talked about consumer leadership in academia, both in terms of research and education. And we found studies that talked about consumers being involved in end-of-life care service leadership. And I'll break that down. So, as I said before, there were examples of consumer leadership in learning and teaching. So that included things like consumers being involved in teaching medical students or having medical students go to within a palliative care service setting as part of their assessment. So there were some great examples of that, and I think that's really important, and I'd love to see more of it. There was also examples of consumers in leadership of end-of-life care research. So that did include some co-produced studies, that included some studies where consumers were involved in setting the agenda of research. Unfortunately, we also found studies where that was quite tokenistic. And there was one study in particular that I was quite scathing of, that my colleagues don't want me to be too scathing of, so I'll try and tone it down. And it's not just this one study, it's a lot of people use this kind of language. But there was one study that talked about co-researchers. And I was really excited because I thought, oh, that's great. They're talking about co-researchers. That sounds like it's really sharing ideas and things are being done collaboratively. But then when I looked at the authorship of the study, there was no consumer co-authors. It was just clinicians, which again I think is fine. That can happen. But then to claim that, I wouldn't necessarily co-publish with a nursing academic and call them a co-researcher, but then not have them on my authorship team, for example. So I found that problematic, and I should also point out, though, it could actually reflect that the consumer co-researchers on that project might not have wanted authorship. I'm making a lot of assumptions there as well, but I think it's just important that we need to think about the language that we're using. If we're claiming we're being co-productive, then co-produce. Otherwise, don't claim that you're actually doing things collaboratively if you're not. That's fine too. And also in teaching, I saw less examples within the included studies of consumers being a part of curricula and assessment design. So their stories were often, part of a lecture, or they were part of an assessment, but they didn't actually decide what the curricula were or what the assessment design was. And so I think actually we're missing out on some potentially really insightful education for our future medical professionals, because I think they need to learn from the people who are affected most by their care, which would be consumers. In terms of service leadership, there were 4 studies that we included in the systematic review. One was about communication skills training, which we've heard some brilliant work that's going on in terms of communication training in end-of-life care. The study that was included in the systematic review on communication skills was actually a systematic review in itself, and they looked at 153 training, end-of-life care training modules, 7 of which were co-produced, which actually is higher than I'd expected, and that was great to hear. And then the other 3 studies about service leadership that were included in this systematic review were about various bits and pieces. One was about a peer-led service that was offering sort of counselling and support for other carers. But one thing was that there was only 3 of those that were included in the review, so it's a little hard to tell. But there didn't seem to be any established structures for consumer-led initiatives within service settings, which is probably not a surprise. But what I would love to see moving forward is having consumers actually part of that decision-making process about what structures do we need for consumer-led initiatives. Okay. So that's all I'll say about that systematic review. I'll also talk briefly about another study which some preliminary analysis has been done, but I don't have a lot of data to show you today, but I'll just talk about some of what I have been finding. So, since that systematic review, I've been interviewing palliative care and end-of-life care consumer leaders and their colleagues. Notably, since that systematic review, there have actually been some really exciting and interesting collaborations, one of which is Palliative Care Australia have begun I don't know that they have a name for it yet, because that was something that people were talking about, but essentially a lived experience advisory board. So something at the highest level, Palliative Care Australia initiating something where lived experience is really embedded was very exciting. So I was interviewing them and various other people about consumer leaders across the sector. And I have 3 small takeaways. As I said, I'm not going to go into data or details, but the first small takeaway is that when collaboration with consumers is sort of embedded within hierarchies and you have people at the top level of organisations setting the tone and saying this is what we need to do, we see that happen more. I guess Palliative Care Australia was a really good example where the previous CEO, Liz Callaghan, did actually implement this lived experience advisory board and set that tone, and so a really useful and engaging initiative began. The second takeaway is that often people think that co-production they say, it's going to take a lot of time and it's going to take a lot of resources. And certainly in some instances, it can take time and resources. But what was really positive to see for me was that people said that once they had those structures in place within their organisations, it became easier the second time they ran with a project or the third time and the fourth time, which makes sense. I mean, we'd probably expect that. But I guess it's just a nice counter argument to people who say, it's too difficult. Is to offer, well, it can be difficult at first, but the more you do it and the more you practice these things, the easier it becomes, which seems very self-evident as I say it out aloud. And the last small takeaway is to actually ask the experts. So I was looking at a range of organisations and settings, so I'm still trying to actually work out how to generalise the point that I'm about to try and make. But essentially, in whatever project it is, if you're collaborating with consumers and you're not sure how to do it, most people found that by asking them how they wanted to be involved and what kinds of supports they could offer to be involved, that often led to the best outcomes. Again, it sounds really self-evident, but in instances where people had asked consumers about how they wanted to be involved, that often led to the smoothest projects. Okay, so in summary, because I'm probably right at time, there is some consumer leadership going on in palliative care, and there's certainly things that are happening beyond that systematic review. As I said before, there are things that are not being published about that are happening, and so I'm not trying to say that those 11 studies that were included in the systematic review represent the only consumer leadership within end-of-life care, but I'd still like to see a lot more. And because we need more to be happening, because there's some happening but not enough, it means we're actually missing out on so much of that experiential expertise. And I mean, I think we heard about that then in terms of it is that lived experiential expertise that can often lead to importantly more positive outcomes for people and I guess a nicer way or a more individually respectful way of dying. And I guess my last take-home message is just to try and avoid tokenism. I know I probably bang on about it a lot, so if you've heard me talk before, you've probably heard me say the same thing in the past. But But I think it can be really easy for us to fall into tokenism, but let's try and fight it together, because a co-produced palliative care sector, I think, is a better one. I'll leave it there. Thank you.
Thanks, Brett. And such important messages, and the resonance between the idea of co-production and so much of what we've talked about today, particularly around the sort of the community's engagement and the fact that palliative care is actually all of our business, I think is really true and valid. We've got a few minutes for questions. Does anyone have any questions for Brett? Yes. No, it's fantastic. You're very reliable.
Thank you, Brett. I couldn't agree more with your sentiments, I must confess. But I'm I'm not playing devil's advocate really, but it is the case that as human beings we get on better with some people than others, and we're more productive with some people than others. So in fact, the person or the people that we engage in our team as consumer advocates or as partners with lived experience, which is how I probably prefer to conceptualise it, is very important. Have you got any idea how we can sort of manage that pathway?
Absolutely. I think in terms of throughout my professional relationships, it's not been whether somebody has lived experience or not that's necessarily made them somebody who I've gotten along well with to collaborate. So, and I know that's not the point you're trying to make, but I always think, I used to hear that sort of question a lot in the mental health space, where sometimes it came with a sort of a hint of, these people are difficult people to work with. Again, I don't think that's quite what you're trying to say, but I guess I always think about, well, there are various people that we have to work with that are more difficult than others, and it's not necessarily just that lived experience determines that. I guess I would say, just back about this team, where the second author was a consumer researcher who was part of our team, was a really easy person to work with, came with 1,000 words just that he wrote on a Saturday and in his own time. So I also take your point that there are certain people who are easier to work with as well. You look like you're about to follow up.
Well, my follow-up is, so you're saying get over it, Diane, and
Well, no. Because again, I would collaborate again with Alan at the drop of a hat. So not necessarily get over it, but that there are difficult and easy people across lived experience and not.
Thank you for the question. Kerry?
Hello. Thank you so much for your presentation. I'm wondering if you could speak to are the terms consumer and lived experience forms of tokenism?
So I should start by saying I use the term consumer just because that's what's used in Australian policy, and it's all of these terms are problematic anyway. Because the other thing that is often on my mind in this area is that a lot of people do have lived experience as well as other roles, and so there's also power issues within that, and there's also power issues around whose words, whose voices we hear. That's not really answering your question, but other than to say I think that language is problematic and we need to pay more attention to it, I'd also say I'd prefer that decision to be made. I don't have lived experience and I don't identify as a consumer, so I feel like it's not my place to say, and I'd love that to be a consumer-driven discussion.
Professor Strickland?
Thank you very much for your presentation, Brett. One of the challenges that I faced involving consumers or public patient involvement, as I prefer it, is at the point when you want to involve them in the co-design. At that point, quite often you don't have funding, and it doesn't sit well, and it feels like exploitation at that point to be demanding sometimes quite detailed input into co-design. So I'd be interested to know how you overcome that challenge, because it really,
otherwise we have to wait until we get funding to invite consumers on, and we may not be really addressing the consumer questions. So how have you overcome that challenge?
Thank you. It's a really important point, and I don't necessarily have all the answers. It is really tricky. Even with this project as well, as I said, Alan was our consumer researcher that was part of the team and actually dedicated a lot of his own volunteer time. Later on, we were able to get funding for him to come to a conference, and we were able to do a lot more things later on, but it's definitely a concern that I share. What I have been trying to do, and again, this requires success in grant funding that also is a challenge for all researchers, but is to try and build that into a grant proposal that the co-design would be part of the grant, and then hopefully you would get funding for that, and you could build on from there. But again, that also relies on the resources that I think we all as researchers face. So it is a challenge, and I don't necessarily have a great answer other than hopefully with more grant funding, and the more that this becomes recognised as an important area, then hopefully things will change. But I would love to work with everyone on how we can improve that.
Thank you.
Yeah, thank you, and wonderful place I think to finish on there, Brett. So thank you so much, Brett, for your presentation. So we've just reached the end of this session, everybody, and now we've got I think a 10-minute tea break, if that's ish, 10-ish minutes. I don't want to too far afield. After that, you may remember that we've got a panel discussion that will be being recorded and hopefully eventually broadcast, and so we're all very excited about that. So please don't go too far. Look forward to seeing you again soon, and thank you so much for all being involved.
national broadcast to chair a panel of our distinguished speakers on good living and safe dying. So over to you.
Thank you. Thank you, Karen, very much indeed. I shall shortly ask you to act up a storm and clap wildly beyond your numbers, because we are going to record this, I'm delighted to say, for use on Saturday Extra, probably towards the end of August, which is, I think it'll be wonderful, actually. I recorded a not dissimilar panel last year at the Sydney Writers' Festival with two intensivist doctors, and just had a fantastic response from our radio audience, so which I think all contributes to this idea of much better discussion around death and dying and what constitutes a good, safe death and dying. So I'll do my little introduction and then I'll ask you to clap and I shall ask you to, perform. So, now, it might frequently be cited as one of life's two certainties, but when it comes to talking about death, and particularly how we want to die, the subject feels a little taboo. And the notion that death can be pretty reliably predicted, I know, is very much known in circles around here, but the fact that by and large we don't talk about that death until 2 days before seems to be an extraordinary condemnation of a range of things in our community, and that's what we're going to try to talk about today. In 2014, a Grattan Institute report revealed that 70% of Australians wanted to die at home. Yet despite their wishes, half died in hospital, a third died in residential aged care, and just 14% managed to die at home. Now, is this the result of poor planning or an even more radical thought? Might the hospital, in fact, be a very good, rational decision, and that is what we also need to talk about rather more? What, in fact, does good living and safe dying mean to Australians in the 21st century? Because they mean very different things to different people, but the more that this is a discussion in the community and a decent conversation, I think the better. So this afternoon's panel work at the forefront of this issue and each in their own way lead the charge to ensure that Australians enjoy a good death. I'll introduce you to them. Dr. Kerry Noonan is the co-founder and executive officer of the Groundswell Project. It's a world first non-government organisation dedicated to raising death literacy. She's also a clinical psychologist in palliative care. Professor Imogen Mitchell wears several different significant medical hats. She's Dean of Medicine at the ANU Medical School, and she's a senior intensive care specialist at the Canberra Hospital, and I believe is currently working on innovative decision aids and audits to improve end-of-life care. Miss Nikki Johnston is a palliative care nurse practitioner at Clare Holland House, which is an inpatient palliative care unit at the Calvary Public Hospital in Canberra. And I'm very much looking forward to talking to her about her inaugural National Nursing Trailblazer Award for her contribution to improving end-of-life care. And Dr. Suzanne Rainsford is a rural GP who's made palliative care services in the southeast New South Wales region a priority, and she's particularly researched the gaps in our ability to provide a safe death. Again, there's this lovely phrase, in our rural communities in particular, because she contends that there really is a difference between rural and urban areas. And she's conducted one of the most important studies in this space to date. So, ladies and gentlemen, please welcome our panel. Brigades of people here today. Okay, let's go to death literacy first, which is this very interesting idea, I know, Kerry Noonan, that you've really trying to normalise conversations around death and dying. What is the matter with the way we currently have conversations, or the neglect of them, which seems to be the main thing that you're concerned about? Why so?
Well, we're having conversations about death and dying too late. That's probably the key issue. We're having them in hospital when the proverbial kind of hits the fan, rather than way downstream when when research, there's lots of research to show if we have those conversations upstream from a health crisis or an experience of a change in your health, then you're more likely to have better conversations down the track with your care providers and with your family. So upstream is the message.
That statistic I quoted, that it is believed, I mean, no one has the exact stats, that the majority of people, up to a half possibly, have conversations only in the last 2 days. That seems incredible. Do you think that's a fair comment?
Well, I think there are clinical conversations which are in a medical setting, and there are social and family conversations that perhaps are less recognised in our broader conversations and perhaps even our research. Some of the research that we were doing at that we've been doing at Western Sydney University shows that when families are caring at end of life or caring for someone who's dying the last few weeks of life, they're having conversations and they're developing skills and knowledge, and that's where the term death literacy comes from, is that there is this learning and this experiential learning, this hands-on learning that people were experiencing by caring and by being part of it. And conversations were a big part of that. Talking, negotiating with care providers, negotiating with other family members, negotiating with your care network. So, that care network can be as big as 30 or 40 people, and as small as 4 people. But we found on average there's about 16 people in a care network to care for someone to die at home. So that takes a lot of negotiation and conversation, and it's not always with the primary health care, the primary person that we as health professionals might have contact with. So there's lots of conversations happening often.
And did we have, your thesis, I think, is that we had more of these in times gone by?
Yes, and that's not just my thesis, but I think we've talked a lot about this today. I mean, let's not romanticise the amount of death that we had in the community 100 years ago. There was a lot of it. But certainly you had to kind of pull your sleeves up and get involved in death care and dying care. And let's not romanticise that. And women were mostly doing that work as well. But certainly there's been a massive change over the last kind of century about the amount of hands-on care that we've been exposed to and that we do.
Now, Professor Mitchell, those 2 days, or the difference, it's interesting you make the point between, say, clinical discussions related to death and what I was going to say, real discussions. That's not fair. You'll hate me saying that, but you know what I mean, discussions that, which bring non-trained people in. 2 days is surely far too late, isn't it?
That's only going to be my opinion. I mean, I suppose you mentioned the sort of sudden discussions about death, and I guess when I'm faced as an intensive care specialist in the middle of the night at weekends, you often get a sense that the family or patient has never had any inkling that this is about to happen. Now, I'm actually pretty certain that's not true. It's just probably it's never been translated perhaps in a way they fully understand the consequences of their disease process, that one day this is actually going to catch them and they're actually going to die from it. So to me, it's about going upstream, painting the picture clearly with patients and their families or carers, such they know that the roadmap will in the end reach a certain point whereby there is nothing in terms of intervention to support cure, that we then move to another pathways to support symptom control or actually decide where the place of death should be. So my challenge is it's an in the middle of the night conversation often, and it's often with an unprepared patient or family. And what can we do to actually change that as a community to move those conversations
further back,
upstream? And the difficulty.
And do you think it can be done?
Well, I think that. I mean, the answer has to be yes. Mm-hmm. The difficulty in the clinical environment is that we're not very well set up for that in as much as skill set And secondly is, you know, as a medical oncologist told me, who is a wonderful communicator, she said, you know, I do not have outpatient time. We have 10 minutes per patient. There is no way you can have a proper end-of-life care conversation. So I think even structurally, we can change that. So I guess, to my mind, yes, we can have those conversations earlier.
But not under the current system.
But I think it's quite challenging under the current
and Nikki
system.
Johnson, how do you see this?
I think what's really important with the work we're doing, so I actually work in the community and residential aged care, and we've taught people to identify people in their last 6 months of life, and then we actually do the conversation not in crisis. We sit down together, a GP, myself, the staff from the facility, the resident, the family, the alternate decision maker, if there is one, and we talk about the goals of care. So it's not whether a hospital is right or wrong, it's whether does that fit the goal of care. So example is a lovely Italian gentleman that I was looking after. He had advanced dementia and was bedbound in a nursing home, and I met with his wife, and there was a question around, well, if he gets pneumonia again, does he go to hospital? And her first instinct was, of course he does. He's sick, he goes to hospital. And then going through, well, what's actually important to you now? What are we trying to achieve here? And it came out that it was actually much more important to keep him comfortable in a place that he knew, because of his dementia, transferring him to hospital was going to make him uncomfortable. So by the end of that conversation, we kept him there. We didn't transfer him to hospital. So that is definitely...
And how long did that take, that conversation?
Oh, about 2 hours.
Yes, right.
And do you know what though? 2 hours of really good work, and you get it all documented. You don't have to go back again.
Is that your experience, Dr. Rains?
Sorry.
Dr. Rains, no, I'm going to because I mean I think this is a terribly important conversation. Does this ring true with what?
So the advanced care planning is not just a tick box. It really requires a conversation, which is time, and it may not be achieved in one session. It may be just starting the conversation about advanced care planning in a general practice setting, and it may evolve over a number of weeks. But I think the GP is in a good position to assist with with goals of care and planning, because there's a relationship
that is there. Dr. Noonan's talked about a trigger event often. Prompting these conversations, and I think what you're saying is get before the trigger event, which is invariably crisis-ridden. Now, how does that sound to you?
Yeah, I think it's really, really important. So the older folk with with dementia, once they've lost capacity, it's then too late, and it falls on the responsibility of the family. But if you can have that conversation beforehand, before they've lost capacity, then that really, assists the family, assists the healthcare.
But does the family? Sorry to interrupt you, but does the family push back at some point?
Often, sometimes.
So
sometimes.
Because I can imagine they might when they're not ready to yet have that conversation.
Yeah. But if you can have the conversation with the patient, with the person, and have a knowledge of what's important to them, then the GP, when they've lost capacity, or they're had a they're in ICU or they're in aged care, when advanced care plans need to be updated, because it's not just a one-off document, it has to be reviewed. But if the GP has had a conversation with the patient beforehand and knows what's important, then that just makes it easy. They can say to the family, well, look, we had a really good conversation. I had a really good conversation with your mum, 3 years ago, and she was really quite clear. This is what she wanted. This is what she didn't want.
But look, I was going to get onto it later, but the advanced care planning, again, that's a bit of a surprise when you start to look at it, how little advanced care plans are actually completed. I thought it was vastly more popular than it turns out to be, and you're nodding here, Professor.
I mean, I guess we've looked both locally actually and across 9 hospitals across the nation in terms of the percentage of people dying in the acute care hospitals who have advanced care plans, and sort of generally it's about 12% of people who die, and then if you get to the intensive care unit and they die, 3%. So it is currently not a pathway of engaging people in conversation, you know, one of the challenges certainly for an intensive care specialist, not that I come across it as you can see that often, but when you do, it's actually not that helpful because the context can be so challenging.
What do you mean?
In that, you know, it can be very specific as saying what they do and do not want. The difficulty is, I mean, as I had someone say to me, you know, Imogen, I do not want to be resuscitated. And, you know, you sort of say, well, if you had aspirated on an apple piece, do you want me not just to watch at the age of 51? And I go, oh, you have a good point. So I think, you know...
So healthy people can't quite imagine.
And I think, you know, you have to just, you know, be kind of cognizant of what context you're currently looking at. So I personally, at the moment, don't find how they're written as particularly helpful. I think what is helpful is to kind of get a sense of what's important to the patient at the time of, you know, into their dying days. And the families or carers need to have a big understanding of what that looks like.
Kerry?
Well, I wanted to add to that it is, I'm going to get a bit specific on the language here. An advanced care directive is the piece of paper where we write the directive down in advance. An advanced care plan is that kind of conversation. I think that's an important distinction and an important part of the conversation that we're having, because lots of people are having planning conversations and they can happen in all kinds of contexts. And so I think that's one thing that we ought to kind of think about as well. Certainly in the community, what I see is a lot of people having social conversations that are adding to people thinking about, or at least understanding, what an advanced care directive is.
But an advanced care plan conversation is the ideal.
And that it's that value stuff that takes time that Nikki's already talked about. If you know your neighbours and your mates and your girlfriends have actually written an advanced care directive, and that's talked about in a normal kind of context, then again, that kind of brings those conversations upstream. I don't think we have enough evidence yet or enough understanding of how those conversations in the community kind of trickle down to the actual piece of paper at the end. And then the piece of paper, how that actually changes, and Kathy and others might be able to talk directly to this. There is some conflicting evidence about what that directive does and doesn't do when you're at the coalface in emergency and other places.
Can I just make a comment? I think in residential aged care we have an enormous opportunity. Everybody in residential aged care has palliative care needs. Everybody has life-limiting illness, whether it's from diseases or whether because they're old and frail and old. So I think that's a real opportunity to sit down and do a really clear plan. Now, in our plans, we have a lot of do not transfer to hospital. So we don't usually talk about resuscitation. We talk about whether to transfer to hospital or not. So that's very upstream. And if they say they don't want to be transferred to hospital, then we put in place all of the end-of-life medicines then and there on that day. We go through their medication charts and de-prescribe medicines that they don't need. So we do all of that at once. And we have a plan so that if someone with vascular dementia has a stroke and starts having a fit, we've got a seizure plan. You know, we're looking after people with pulmonary edema, with infections, with acute abdomens, with bowel obstructions. We're doing so much, and it's not in hospital.
Look, I think what I sort of take, though, is, see, all of this discussion, I think, still cuts across whether people even know how to prompt a conversation like this when they're healthy and well. A friend of mine a while ago started making plans for her prepaying for a funeral. And we all said, my goodness, what's the matter? We were terribly worried that she was going through some stage that we hadn't properly picked. And in fact, I think we passed on such a feeling that she stopped talking about it altogether. And I'm just listening to you all and thinking, well, we may not have actually helped her at all, or ourselves, because we cut it off, if you see what I mean. Now, how do you... Because Kerry Noonan, it seems to me this is what you really want to prompt. You want to prompt us to think about how we realistically, in a very, coherent, constructive fashion, start introducing this more into our lives.
Yeah, look, there's no doubt it's hard. It's no doubt even for me, for a friend of mine having a conversation with me in the same way that you've just described, that would also be hard for me. Because our emotions are involved, our love, our connection to another human being is involved.
Well, there was the assumption with her, I'm terribly sorry that there was something dreadfully dysfunctional going on and that we'd missed it.
That's right.
Do you know what I'm saying?
Yeah.
So you have to get past that, it seems to me.
Yes. And you do, and so making these conversations kind of more normal.
Yes.
What we know from some of the research is that only about, we know that by the time you're 16, most of us have had, 50% of us have had experienced the death of someone close to us. Yet, only about 10% of us feel okay about speaking to kids about death and dying. That only about 9% of us are learning about death and dying from community events and things happening in our community, but 20% of us feel like we live in communities where the conversation about death and dying is actually part of the everyday. So there's lots of conflicting kind of information and evidence in all those statistics, but I reckon one of the key things is starting to really recognise the normal everydayness of these conversations, that they are as much a part of thinking about planning for a wedding or planning for a vacation
or a birth.
I mean, the time we spend planning for a birth, yet we spend very little time planning well for death.
And if we don't plan for death, it's going to be bad. That's it. Full stop. We have to plan for it. It's going to happen to all of us. We know, the majority of us will know that it's going to happen. I know there's accidents and everything, but the majority of us have an opportunity to plan. And if we are able to plan and tell people what's important to us, do you want to go outside? Do you want milk with your tea? Do you want your dog sitting by your bed? Who's important to you? Who's your family?
Well, of course,
we don't ask those questions.
No, because a lot of people may trust that this will actually take care of itself.
And it doesn't.
You know what I mean?
It doesn't. And often people end up in hospital and dying in hospital because we didn't have a conversation.
Now, I'm going to bring in Professor Mitchell here because I know this is something that you care about because, the Grattan Institute, in its big 2014 discussion, said, dying well, in the last year of life, many experience a disconnected, confusing and distressing array of services, interventions and relationships with health professionals. Many do not get enough palliative care. Now, that if we can move on from that to this whole argument that most people want to die in hospitals, do not want to die in hospitals, I think you really question the rationality of that.
So I guess there's a couple of aspects to that. I mean, so we land up with the fact that most people are dying in acute hospitals. So that's the first issue. The second issue is, if we're going to experience dying, who should be involved in that dying process? Should it always engage specialist palliative care, or is there a group of patients who actually don't, in fact, need specialist palliative care? But the challenge I have with that, because, certainly, again, the local study and the national study that we undertook through the Australian Commission on Safety and Quality in Healthcare, is about 30% of the 1,700 patients that we looked at dying see palliative care. So 70% are not seeing a specialist palliative care. That's not to say they didn't get palliative care type of relief of symptoms, but it's just saying that we have a resource that's either underutilised or more likely under-resourced. So I guess, and I'm not a palliative care specialist, but I worry sometimes is that when we talk about end-of-life care, that the narrative is very much alongside the palliative care specialists, but they're actually not involved necessarily in every death that's happening in the acute care sector. So I think we need to speak more broadly about how we manage our patients at the end of life. Should we be involving palliative care more frequently, or are we, as non-palliative care specialists, able to manage patients that they're dying? And I have to say, I'm not convinced, because having been involved in a number of deaths, as you can imagine, over the decades, I worry a lot that they do not get a good death.
If they're not with sufficient palliative care or at home, is that what you're saying?
Well, I can't make a comment about home, because, but certainly within the acute care sector, I worry that they don't have adequate support and relief of symptoms and support of the families.
And
yes, Nick.
Can I say something a little bit controversial? I think that we're medicalising dying too much. We've got to normalise it. It's all going to happen to us, and by medicalising it and making it medical failure that someone dies, that just sets up this whole community expectation of what acute care does. You go to acute care and you get saved. Well, no, that's not going to happen every time. So access to specialist palliative care is really important, but access to other people is really important as well in the community if we're not going to medicalise dying, if we're going to normalise it.
Yeah, but isn't this whole discussion around palliative care, and I might even bring in Dr. Michael Chapman, who's Director of Palliative Care at Canberra Hospital, the research is suggesting that palliative care itself is far too narrowly defined, Michael Chapman, that it's seen as it should be far more broadly used and brought in much earlier when somebody is, say, has 6 months, and they know that you've roughly got a trajectory of, say, 6 or maybe longer to go, whereas it's brought in towards the end and seen as, this is not fair comment, last gasp work, if you know what I mean. Now, do you yearn for a broader understanding of palliative care?
Yeah, thanks for the question, and I absolutely do. And I think the comment about it being a last gasp, while it's on some levels unfair, is actually unfairly also how it's often perceived. I think in our community at the moment, both amongst clinicians and our general population. But we've got really, really good evidence, really compelling evidence to say now that early integration of palliative care, early offering of palliative care to people who've got some kind of serious illness makes all kinds of really beneficial differences to the experience of their lives from that point, the impact of how they are, how that is for their families, what sort of health outcomes they might have, and even in some cases, maybe even how long they live.
Yes,
and
there's
so
some evidence to show that they live longer.
There is, and that's certainly an area for further study. But I think, to me, one of the things that this is fundamentally about is about a misunderstanding of what palliative care means. For me, when I see patients, a lot of my job is obviously introducing these ideas to patients, and I do normally say that palliative care is about, for a person who's got some kind of serious illness that we can't necessarily take away, it's about doing everything we can to make sure each day is as good as it can be.
And when you say early intervention with palliative care, what do you mean? Try to help people understand what you think is ideal.
It's another really good question, and it's probably something that's a little bit context specific, because early might mean different things in different situations, appropriately mean different things in different situations. But I think probably a fair way of thinking about it is that it's something that could or should be offered well before a person absolutely needs support.
Will you terrify them if you use the word palliative care?
And that's exactly the point. And part of the reason for, I think, why it's such a fundamental shift to the way that we're offering healthcare is that palliative care is something that people worry about, and not just community members. I think clinicians are also really scared of using these words and the meaning that they have, which is
even
why
among their own peers, you mean?
Absolutely,
Really?
yeah, absolutely. Yeah, I constantly have conversations with my colleagues, doctors, nurses, and other people working within healthcare who really understand my work very differently from me.
Really?
But it quite transparently is all about trying to make sure for people who've got some kind of serious illness, making sure each day is as good as it can be, in whatever way that might mean. And it's actually not a scary idea. When you talk to people about it like that, actually people pretty quickly say, yep, I want some of that.
I saw someone recently who was told that they were handed over to palliative care, to our team.
That was the verb.
They were handed over. That's often said in hospitals, but they were handed over, told that they had 2 weeks to live. And this gentleman was, I'm a psychologist, so he asked to see the psychologist. It was 5 weeks past the time he was 3 weeks past his use-by date, as he put it. But he was stuck in trauma because he had been told and handed over in such a dramatic way. We can't do anything for you. There's nothing we can do. You've got 2 weeks to live. We're going to hand you over to the palliative care team. He was stuck, and one of the ways that he kind of had to become unstuck was to really think about how did he want to live, and that's what that's the part that Michael's talking about. But once he did that, him and his family started to talk about, well, how are we going to do this? They got energised about how are we going to support each other now for however many weeks or days Dad has left.
Do you know how long he did have?
He's still going, as far as I know.
Oh, isn't that... And look, this is very interesting. And Suzanne, I know I'll come to you, Nikki.
Okay.
Suzanne, I wonder the repositioning of palliative care, which I've been reporting on for years and years, usually saying there isn't enough of it, but whether the repositioning of it as a term might actually aid this very death literacy that we're talking about. I mean, how do you introduce it to your patients?
Well, I'm a palliative care specialist.
Oh, you're a palliative care. I'm sorry, I thought you
GP,
were... Pardon me.
So now when patients come to see me, they're coming to see me as a palliative care specialist. But even then...
I'll ask you this, because I'm sorry, I was getting confused.
Yep.
Do you think it can be usefully repositioned, just even in the use of its language, if you know what I mean, to make a difference? Or not?
I think certainly some people are really afraid of that palliative care term, even when they're coming to see me. I'm not sure whether it.
Well, I think I would be, to be candid.
Yeah.
I'm just picking up what a possibility is on offer here.
Because they're still aligning palliative care with I'm on my last legs, instead of I've got so much more time. I've got some time to live, and let's make it quality time. You mentioned the word palliative, and everyone
freaks. Nikki.
So I think what we've tried to do is to make it usual care. Okay, so it's not something that has to be introduced. It's usual care. It's part of your care. So that's what we've done in residential aged care. We are part of the care team, so everyone's getting it, and that can only be done through true integration, which is really important. If we don't talk about this and offer it, the risk we have is people suffering. They're suffering and they shouldn't be suffering. I have so many people when I turn up to the door, thank God you're here. Thank you. Someone can help me. Someone can help my family, and someone knows what to do. Someone's done this before.
Someone's done this before.
Someone's done this before. Someone knows what to do. It's okay. We're safe. We're going to be okay.
Professor Mitchell?
So I think palliative care in some respects has already reframed us, the other clinicians, if you like. because one of the challenges I think palliative care faces, a little bit like intensive care, the owners of the patient, and I hate to use that term, but in the hospital, patients are owned. If you start threatening the ownership of the patient, the clinicians become very unhappy. So if I go in and say, you know, this patient really needs end-of-life care, they get very threatened that you've now challenged their way of managing a patient. If I use the language of palliative care, help me understand the goals of care. For some reason, that change, tweak in language suddenly makes them relax. And now we can start talking more realistically about what the next step should be. So I think already palliative care, certainly in this organisation, has changed the landscape in terms of, you know, let's talk about the goals, not just about, you know, are we going to put this patient for resuscitation or not? And that's much less confronting. And I think, you know, to reframe palliative care is a good thing, and it allows patients to have a much better end-of-life care experience.
Very interesting. And look, before, because I want to go to questions, but I must talk about the aspect of this before we are having our conversation. While we are having our conversation about voluntary euthanasia and assisted suicide, which clearly occupies the headlines quite a lot. Now, I just wonder, and I'd just like each of you to give a quick answer if you could, do you think, and various states are bringing in legislation on, is this debate assisting people to have a better conversation or not? I wonder what you think, Karen.
It's certainly increasing. There's certainly been a number of conversations. What I've observed is that a lot of the conversations do seem to be fear-based. That worries me a little, because that's certainly not my experience at the coalface of death and dying. So that aspect does concern me a little. There isn't a lot of conversation about people kind of having normal deaths. They're not very sexy normal deaths, but many of us here see lots of normal, natural deaths. And that for me, in terms of the discourse, has been a little challenging.
Professor Mitchell.
I think that it's not that I disagree with the conversation or that it should take place. I think that the challenge that I have, it just really is going to focus on such a few numbers of deaths that we're really then might miss the main game in the conversation. And you talk about, you know, the limitations we have in resources of palliative care. I mean, that needs to still continue on as a mantra, that we still need more resources in terms of palliative care specialists or more broadly. So I guess it's not a conversation that's negative. It's just I don't want it to derail it from the main game.
Nikki?
I think any talk about death and dying is good. Any kind of bringing it up, conversations. We've had different groups in Canberra. Lots of people have been talking about it. My patients have been talking about it. They've asked me for the pill, you know, that kind of thing. That happens quite regularly. So I think that's a good thing, in my opinion.
But if it worries people and they start to believe that there's no alternative but acute pain at the end, which has to be alleviated, and indignity, does that help?
So what our job is, so palliative care is about living people, okay? We don't do a hell of a lot with bodies. We are mainly looking after alive people. So if we go and talk to them and we tell them that we're here, we ask them what's important to you, what are you scared of? If they ask me to have suicide, which people do, I say, what is it about life that's so hard for you? How can we help you? And, you know, I've never had a case. I've been asked that question multiple times, and they've all died without voluntary assisted dying, and I think they've died well.
Suzanne?
I think in the community, the topic of that, I think that is increasing the death conversations in the community about dying. I think,
which is a good thing.
Well, it's a good thing, but sometimes it's misinformed, and so they're not necessarily aware of what palliative care can offer. So I think in that, as far as having conversation, and I think that's a good thing, but it needs to be a little bit more informed.
And Kerry, didn't you tell me about some of the research about what is actually what people nominate as the reasons why they choose, they opt for voluntary assisted suicide?
That wasn't me, but
It was Kathy.
It was Kathy.
Okay, hang on a tick. So we'll just edit this, of course. And presenter looks silly.
Sorry. I could answer on Kathy's behalf, but I don't want to.
Kathy, can you just say who you are and then say what you would tell
Kathy
me?
Eger from the University of Wollongong, the Australian Health Services Research Institute. The issue about voluntary assisted dying is that we've had a lot of attention about it, but actually not many people want to do it, which is good. We think if we extrapolated from the American experience, the Canadian, very similar countries, you would have less than 2,000 people in Australia per year against 180,000 deaths if we had uniform legislation. And I think I'm quite happy to have that as part of a conversation. But I think the issue that we really need to dispel is that people are choosing that option because of pain and symptom control. That is not the international evidence. The international evidence is that people choose voluntary assisted dying where it's available, really for existential reasons. My life has got no value to me anymore. There's nothing I enjoy doing anymore. Pain and symptom control in palliative care in Australia is excellent, and there is no reason for anyone to choose voluntary assisted dying because of pain and symptom control. But we do need to recognise that there's a bunch of baby boomers, and I'm one, coming through the ranks who've been in control of our lives, and we're also going to be demanding that we have some control about our death. So we can't just say, gosh, if we improve palliative care, nobody will ever want voluntary assisted dying. We have to do both. We have to actually really improve availability of palliative care, but we also need to recognise that people have a right to make choices and will demand to do so whether or not we as clinicians in the health industry are comfortable with that. That these are social issues, they're not health issues.
To me, this brings us kind of back round to the issue. I mean, when we talk about autonomy and we talk about meaning in our life, to me, this kind of brings us full circle back to the idea of how are we having the conversations about what it means to be living with a life-threatening illness. What does it mean to be have a family member who's dying? How am I managing that in my family, in my life? And that's where the values-based conversations that we've been talking about as well can really come to life as well. For some people, there'll be a choice around voluntary assisted dying. For other people, it might be, well, actually, I'd like to get that caravan and take it for one more run. How can I do that? How can Nikki help me do that? How can my doctors help me go for another run in the van?
Look, I'm going to throw it open to questions for about the next, 10 minutes or so? 10, 12 minutes? So if you'd identify who you are and pose a question, you can make a short statement, but don't keep it to a minute if you possibly can. So anybody, yes, do. Thank you.
Hi, I'll start it off. It's Marguerite Kelly. I'm doing a PhD at the Australian National Uni, and I have previously worked with Kerry on the Death Literacy Index. So just in summary, I'm keen to get the panel's opinion on this. Today we've heard kind of wonderful speakers, all from different backgrounds, all keen to improve the end-of-life experience, and it's been really fantastic to see. And we've heard that, end of life's everybody's business. But what strikes me throughout these presentations is this intersection between the human and the professional. So we've heard how, communication, compassion, kindness, empathy is so important in delivering care. But all of these seem, primarily human to me. So I'm just curious to what the panel see. Is this just an extension of, not sitting with death and dying, that we're kind of looking to, train our medical doctors on how they can do these things that are fairly...
in other words, they're just good human values.
They're good human values, yeah. and stuff that is challenging. Like we've heard people working in neonatal infant, care, and this is such difficult stuff. But yeah, it's just been a tension throughout the whole day. So I'd love to hear.
Okay, that's so. Is there Yes, is there a tension? I'm going to ask you, Nikki, because I don't think you see any tension at all by the experience of what you have, but obviously this is something that does trouble people.
Well, me personally, no, but I've done this work for like 25 years now, and I think what I see as a society and a community is that our community values life and living. Our community values the lengthening of life. There's been a lot of emphasis on cure and keeping people alive. A lot of money poured into research about how are we going to stay alive, how are we going to cure disease. And what we're left with is people living longer but not better. So the majority of people I see wish that their lives would end. You know, I'm seeing people in their 80s, 90s. I've seen quite a few that are over 100, and they wish that their life had ended. And you know, they talk to me about it all the time. So look, I think it's our values in this society that we've poured money into cure and keeping people alive. That I don't know what to do with that, because.
Kerry, because you've thought, I mean, this is exactly what you've been involved in.
Well, I think a lesson from Nikki's work is that the work of palliative care is integrated into the practice of aged care. So there's no them and us. Lots of things that we've talked about today actually have been about trying to manage health professionals' values and their response to dying and death. And I think that we ought to, you know, you ask a room like this, who has got their advanced care directive written? And
about
you would think in a
12%.
room, yes, and you would think in a room like this, right, we're all connected with this work, that we would have done that. And we know, those of us who have done all of those documenting things, it's bloody hard to do. And it's a hard conversation to have with your family, and yet we expect health professionals to just know how to naturally do that because they're clinicians. So there is a kind of getting back to that human value of this is one human being talking to another human being about a stage of their life that is actually important, and how can we help them with that?
Is Dr. Penelope Schofield here? Oh, there. She's just gone. What a pity. Because she particularly wrote about she who's not medically trained, she was actually called in to support someone who was dying at home with his family, and she was struck by the lack of specific knowledge that people had around the very last stages and so on. And as soon as they were equipped, they asked her for, you know, is this what we can expect? And he sort of had suddenly had he was sort of sat up, very agitated in the bed towards the end. She said, just lie him back down again, and he died very shortly and very peacefully after that. But the family just did not know what to do in these last sort of hour of his life. And she was quite struck by the lack of specific knowledge as a problem, which really affected me, having been through something like this. And I wonder, Isabel, you know, you're very much at the other end, at the intensivist end, but do you think that that might actually take away quite a lot of the fear if there was sort of specific knowledge given to people about what might occur?
Well, I think this goes back to my previous comment about painting the picture, is allowing, I guess, an upfront conversation of what your journey might look like and what the expectations along that journey should feel like as well. So I think if people, patients, families have a better understanding of what it is and the expectations along the way they might find, then I do sense that it will be better. And it's certainly better for someone like me who comes in the crisis, that the family actually have some understanding, and then we can work with that understanding to say, okay, these are the next step. What I find most of the time, and I say at least 90% of the time, if not more, the families have seemingly no understanding that this is what we're facing, and that is the pointy end of life.
And surely that is at the medical end. I mean, if doctors brief you well, it's immensely calming. Immensely calming.
And I think the challenge again is that certainly in the acute care hospitals, is that many of these conversations are happening out of hours. And unfortunately, the week is made up of 70% of out of hours. Because if you think about it, Monday to Friday, let's be generous, 8 till 6, that's in hours. The rest is out of hours, and out of hours is run by the most junior, inexperienced nurses and doctors and the like. They either haven't had the training, but more likely, because I'm biased because I run a medical school, is that they don't have the experience. And until you have experience, you really don't get skilled at the really difficult conversations.
Nikki?
Can I just say one thing that I talk a lot about, and just an example, when I'm sitting there talking to families about what might be happening in the next few days. One thing that I see very often is that people will either wait for their loved ones to get there, or they'll wait to be alone. So I see families doing vigils, and they say, "Why isn't she dying? We've said, we've given her permission, we've been here, we've said all these things." And, you say, "Well, how about you go and have a coffee or something?" And then the person goes. So there seems to be some kind of, I don't know what it is, but so I was telling a woman this story, and she just sat up straight and she said, "Well, I didn't know that. When I was looking after my father, I wasn't there, and I have been feeling guilty that I left him hours before he died. I've been feeling guilty for 11 years."
Oh, dear. Yep, I've heard this story too. I have heard this story. I know you want to say something, Suzanne, but Kathy, I'm going to hand it.
Yes, I just want to pick that issue up. I think we're getting better at educating and engaging with families about what to expect at end of life. And if a person is going to die at home, that's really, really important. But I did want to pick up that whole issue about preferences. The 70% preference that's always quoted is from population surveys of healthy people who are not dying.
This is people who want to die at home.
Yes, the 70% of people who want to die at home. The 70% of people who say that in surveys are not dying. They're healthy people. And I think what we've got evidence of is that when people are in that situation, both the patient and the family, preferences change as death gets closer. And there's big differences by age group. Young people want to die at home, older people don't. But I think one of the things we need to understand about the future is that you will not die at home if you live alone. No. And the most growing population demographic we've got are 400,000 people at the last census over 75 living alone in Australia. We have to develop models that are not overly medicalised, but don't have a romantic idea of the family all being at home with high levels of death literacy and knowing what to do. We need to understand that there isn't one right model for anyone, and that people's approach will change as death approaches and if pain and symptoms develop, and that we need to be able to be very responsive, and we need also to, I think, to be much better at allowing for seamless transitions of people between home and hospital. People who are dying shouldn't end up in emergency departments. They should be able to go straight from the specialist inpatient palliative care unit to home and back again.
Or maybe we need a new television program, I've been thinking.
Yes, we might.
On, the palliative care units. I'm serious. I mean, this is what I hear, so that we do hear. Now, Suzanne, and then we'll give Michael final word.
Just picking up on that preferred place of death and home. Certainly in rural areas, it's very difficult for people to stay at home out on the farm. And the rural hospital is a very acceptable place, and the rural hospital is, when you say people not wanting to die in hospital, a rural hospital is so much different to a tertiary hospital.
Do you think
in the
so?
city.
You think
Definitely. The rural hospital, it's a familiar place. It's the patient and the family, that's where they've had their babies, where their children if anything, if there's a crisis, they've gone to that local hospital, so they know the hospital, they know the staff know them. And so it's a very different environment.
And much more familial
much
and
more
gentle.
familiar,
And
and a safe place.
And some people want to die in hospital. They should be allowed. It doesn't matter. It's not right or wrong to die in hospital. It's just it's right if it's right for that person.
Quite. Now, Dr. Chambers, and then we'll have to wrap up.
Yeah, thank you. And I think really just to pick up that point, just in regards to the importance of choice and preference, but also to sort of respond to this point about the wish to demedicalise death and dying. We talk about that as being something that we consider important, but at the same time we're very, very happy to continue to medicalise healthcare, you know. And a lot of the healthcare that we're providing now is healthcare for people over a prolonged period of time. People who have, you know, significant illnesses which are increasingly becoming chronic illnesses, which due to advances in healthcare we're able to, because we've done very well. And so people are increasingly spending more and more and more time in the familiar space of, you know, an acute health environment. And so it makes some sense that in fact that's becoming a familiar and maybe for some a preferred place for them to want their care, even at the point of them getting close to dying. And so perhaps it shouldn't be some surprise to us. And that maybe if we want to challenge and change that, actually it's going to be quite a slow process for us to do that, because for many it's going to feel like the right thing.
So maybe instead of chopping the two in half, maybe making acute care palliative care friendly is another way forward.
Well, I'm going to ask you all very quickly then, if you had one sort of lever of power to change things for the better, what would it be very quickly? So I don't want a description of everything, I just want something that, or an attitudinal change. What would it be? Kerry Noonan.
Oh, do I have to go first?
Yes, you do.
More acknowledgement of the death literacy that exists in our community. So asking the question, have you seen dying, for example, in a clinical space, tells us a lot about what people bring to that medical experience. So, bringing to life the capacity, that's what I'd like to see, bringing to life the capacity that's already there. That actually will make our jobs easier downstream as health professionals.
Good answer. Isabel Mitchell.
So I think for me it would be about clinicians taking some ownership, if you like, of the Google map of our life and making sure that we're very clearly signposted as to what we are to expect at each turn.
Nikki Johnson.
I would like to see equal access to palliative care across Australia, regardless of age, diagnosis, or where they live.
And Suzanne Rainsford.
Yeah, and the equal access in rural, but being mindful that rural hospitals are a safe, acceptable place for many people to die if that is their choice.
Well, look, I think it's been very, I think there's some very fresh ideas there, and it's a conversation that we'll have many more episodes of, but would you please thank Dr. Kerry Noonan, Professor Imogen Mitchell, Miss Nikki Johnson, and Dr. Suzanne Rainsford. And thank you very much indeed. I know there's loads more that we could go to, but we will edit this up and put this to air on Saturday Extra, and I'll make sure that Marianne knows when it is and that she can let you all know. Thank you for entertaining us today. Thank you very much indeed.
And if I could just thank you again, Geraldine, for coming, and encourage those of you to go upstairs for the poster viewing. There are lots of really interesting studies for us to share and chat about over posters, and drinks. Oh, there's drinks too. So thank you.